the grossly malnourished lot, and then we also have the overfed, obese lot in our children. And the gaps that exist in our population are really huge and essentially need to be addressed. So a balanced nutrition is an essential for a healthy life and a healthy body. And as they say that the health well-being brings in hope. So I sincerely hope that your symposium today will define outlines to bring hope to the less privileged population in our country. So thank you again. It's been a pleasure to join you all, and I will look forward to listening to you all also. Thank you.
Thank you, ma'am. Thank you for so kind and encouraging words. I'm really thankful to you. Our director, ma'am, is not able to join for some unavoidable reasons. Very shortly, she is going to join us. I would request Shreya to display the screen of for Dr. our chief guest, sir. Yes, Dr. Pradeep Saxena, Senior Chief Medical Officer, National Center for Disease Control, GHS, Ministry of Health and Family Welfare, Delhi, India. Sir has been awarded WHO Fellowship in Field Epidemiology and Leadership Development in Public Health Policy. Till July 2021, was working with Nutrition and IDD Cell in Department of Health Services under Ministry of Health and Family Welfare, New Delhi, and responsible for implementing 2 national health programs related to nutrition. That is National Iodine Deficiency Disorder Control Program and National Program for Prevention and Control of Fluorosis. Also was convener of Task Force on Balanced and Healthy Diets. Working in Central Health Services, Ministry of Health and Family Welfare for last 34 years, including following. He worked as a Chief Medical Officer at Dr. RML Hospital, New Delhi, worked as Director, Central Bureau of Health Intelligence, Head of WHO Collaborating Center on Family of International Classification in India, worked as Director, Central Health Education Bureau, Department GHS. Sir, apart from this, and he holds many professional membership of many professional bodies. Apart from this, the most interesting part which has left impact on me was when you said that please Poonam, try to promote the concept of farm and folk to each and every one in your fraternity. That gave me an idea that how closely you are attached to this subject and how much you want to do for this. Sir, now I request you to give your message to all of us on this inaugural session. Thank you, sir.
Thank you, Poonam ji, for your kind words. Am I audible to you?
Yes, sir, you're audible, sir. You're audible.
Thank you. Respected Professor Nityanand, Madam, who is of course not there, who is not here, Director of the Institute, Professor Husain, Madam, Dean of the Institute, guest of honor of today's event, Mrs. Vandana Sheth, who will be joining from USA, and of course our great coordinator and overall organizer of today's event, Poonam Tiwari ji, Madam, Head of Dietetics Department. Various experts who have joined as who will speaking as a speaker, and all the participants of today's international virtual symposium. I wish a very good morning or good evening to all of you. At the outset, I would like to thank the organizer of today's international symposium, especially Ms. Poonam Tiwari ji, for inviting me and giving me an opportunity to share my thoughts on this at this symposium with you all on this big occasion which our country is observing like every year, National Nutrition Month during September of every year. And as seen from your document of the symposium, the theme of today's symposium is you have kept is Therapeutic Nutrition from Theory to Plate. This is very apt, I feel, because I feel most of the participants are aware that India now faces triple burden of malnutrition, that is undernutrition, the micronutrient deficiencies, and also obesity or overnutrition. So there are three triple burden, And as per the last National Family Health Survey or NFHS 4 conducted by Ministry of Health, the Government of India between 2015-16, there were 53% women in India who were anemic. Just see, I repeat, 53% women in India were anemic. 35% children less than 5 years of age were stunted, were underweight, that is low weight for age. And 38% children less than 5 years age were stunted, that is low height for age. And 20% women and 18% men were overweight, having BMI more than 25. So that means this data, what I told you some time back, this data has shown us that there is a triple burden of disease. In view of such uh, uh, not very encouraging nutrition status in the country, the nutritionist, dietitian community, medical community in our country, and all of you who have joined today have an important role, not only to prevent and treat undernutrition, but also to prevent and manage obesity and related lifestyle diseases. So this you have dual role by planning and advising healthy diets. I hope most of you may have seen the latest nutrient requirements for Indians released by National Institute of Nutrition NI in Hyderabad, ICMR, in September 2020. And in last year, during the time of corona pandemic in April 2020, WHO gave a new definition of healthy diets. That means, which said healthy diet helps to protect against malnutrition in all its forms, as well as also it protects from non-communicable diseases such as diabetes, heart disease, and stroke and cancer, etc. So that means healthy diet has dual role. So here it is important to note that healthy diet would be useful and effective when it becomes part of our daily life routine. Not that one day you prescribe, we have a healthy diet and then you forget. No, it should become part of our daily routine and also part of, thereby making a part of a healthy lifestyle. Therefore, to achieve good health, healthy diet should be accompanied also by physical activity, exercises for at least 30 minutes daily, which is also highlighted for last few years by our central government's movement called Fit India movement. So exercise, part of healthy India movement, adequate exposure to sunlight. We know that India has sufficient sunlight, but there is also at the same time deficiency of vitamin D. So there should be adequate exposure to sunlight, then regular timings of meals, and also adequate sleep. All these changes, healthy lifestyle changes, will only achieve will give us good health, not by having a healthy diet, a balanced diet one day. No, all healthy diet is a part of the healthy lifestyle. That's what point I am trying to emphasize. So National Health Policy of the Government of India released in 2017 refers to focus on preventive and promotive healthcare through actions on social determinants of health. After this, Ministry of Health, Government of India set up various task forces to make recommendations for health promotion, and nutrition being one such determinant of good health. The task force on balanced and healthy diet was set up by the ministry, which had eminent public health nutritionists from all over the country, national institutes, and also public health experts. The report of the task force was finalized in December 2020 and is also available on the website of DGHS, that is dghs.gov.in. You can just go through. I'll just repeat show you slide if you can see dghs.gov.in. So you go through download the report and see the report on the website. Some of the recommendation I will just elaborate today, which is concerning this National Nutrition Month and this seminar. Some of the recommendations to promote balanced and healthy diet. This includes first and foremost stakeholder engagement through advocacy at the highest level and also convergence at the grassroots level. When I say highest level means say at your institute, like if your director and dean madam who have joined today, you have involved them. So that is stakeholder engagement at the highest level in your institute. up to the various grassroots level, all the dietitian, nutrition working in this department. So stakeholder engagement. Then second is setting the approach. Now the concept is setting the approach. Setting हिंदी में जैसे बोलेंगे माहौल, जैसे हमारे हम काम कर रहे हैं हॉस्पिटल में, हॉस्पिटल सेटिंग का माहौल, it should be free, nutrition friendly माहौल, that is nutrition friendly education institute, workplace, hospitals, restaurants, hotels or even old age homes. In सब जगह में setting the approach, we should promote healthy diet and nutrition friendly approach. Next is public health emergency, like we have seen in ongoing COVID-19 pandemic from last year. There's an increased demand for nutrition-based and healthy diet solutions. So public has demanded, media has demanded that provide healthy diet solutions, nutrition-based solutions. So this is the time we should this community should utilize for using all types of media for giving nutrition related messages during such crisis. So because public demand is there, public is receptive to us. Next is for coordinating and integrating multiple stakeholders in the field of nutrition. This task force has recommended formation of an apex body under the leadership of Niti Aayog at the center. And this report has also said that once this apex body is formed, then there is a need for designing a new food and nutrition policy for country. I believe some of you will know that last national nutrition policy of our country was formulated in 1993. That is 28 years back. After that, there is no nutrition policy. Only now Poshan Abhiyan, that is a strategy for it. There is no nutrition policy for last 28 years. So our report has pointed out that now there is a need for designing a new framing a new food and nutrition policy for the country, because a lot of new developments have taken place at national level and international level, keeping all the developments in mind and health status and nutrition status of the population. There is a need for a new food and nutrition policy. Now coming to the next, which Poonam Tiwari madam has been highlighting, quoting from my report, strengthening of food systems based approach. As you know, food systems involve everything or each step from right from cultivation of plants at the farm level, development of poultry, harvesting, processing of food, transporting of food products, then marketing in the private sector shops or in the food through public distribution ration shops, and then subsequent is consumption, and next is storage and disposal of food. So this completes the cycle from farm to fork, और हिंदी में जैसे बोलेंगे खेत से प्लेट तक या खाने के कांटे तक. I repeat this only once we strengthen this entire food system approach, which involves from farm to fork, तभी हम अपने देश में हर इंडिविजुअल को हेल्दी डाइट प्रमोट कर सकते हैं, ना कि कुछ लोगों के लिए, सबके लिए. तभी ये हो गया जब तक हेल्थ सिस्टम अप्रोच हम फॉलो नहीं करेंगे और इसको स्ट्रेंथन नहीं करेंगे. ये करने से क्या होगा, जैसे अभी आपके डॉक्यूमेंट में भी लिखा है, मैडम तिवारी ने भी बताया, दिस विल इंश्योर अफोर्डेबिलिटी, अवेलेबिलिटी, accessibility, food security, sustainability and resilience in the food production and promotion of balanced and healthy diet. Affordability जैसे आप सब मैं थोड़ा हिंदी में बता दूं, लोग इसको स्वस्थ हेल्दी डाइट को खरीद पाएं, अवेलेबल हो मार्केट में, उनकी पहुंच हो, और फूड सिक्योरिटी हो, खराब ना हो फूड, और लंबे समय तक रहे, और फूड प्रोडक्शन मजबूत रहे. तभी ये बैलेंस एंड हेल्दी डाइट संभव है. Next is innovative solutions to promote balanced and healthy nutritious diet. के लिए कुछ इनोवेटिव सोल्यूशन भी हमने बताए हैं. मैं आपको कुछ उदाहरण दे दूंगा. जैसे कि हम सब जानते हैं कि इंडिया इज वन ऑफ द लार्जेस्ट प्रोड्यूसर ऑफ वेजिटेबल्स एंड फ्रूट्स, बट दुख की बात है कि कंजम्पशन उसका कम है. उसका एक मेन रीजन है कि आपको शायद जान के ये बहुत अफसोस होगा कि जो इंडिया में 40% सब्जी फल जो पैदा होते हैं फार्म में, वो वेस्ट हो जाते हैं ड्यू टू वेरियस रीजंस. पहुंच नहीं पाते कंज्यूमर तक, या रास्ते में ट्रांसपोर्ट नहीं है, कॉस्ट फैक्टर है, जो भी है 40%, तो इतना ज़्यादा नुकसान होता है जो फल सब्जी जो प्रोडक्शन तो हो रहा है और लेकिन कंज्यूमर तक नहीं पहुंच पा रहा है। इसके लिए एक तो हमने रिपोर्ट ने सोल्यूशन सिंपल सोल्यूशन बताए हैं, कोई ज़्यादा खर्चे वाले नहीं है, कि फूड को जो सब्जी और फल को डिहाइड्रेट किया जाए और सुखाया जाए या फ्रोजन किया जाए, और उसके बाद और ये काम गांव में विलेज लेवल पे पंचायत लेवल पे किया जा सकता है। उससे कॉटेज इंडस्ट्री भी डेवलप होगी, लोगों को एम्प्लॉयमेंट भी मिलेगा। तो ये ज़्यादा समय तक जो मैंने बताया कि सब्जी और फल वेस्ट हो जाते हैं, तो वो रह सकते हैं सुखाए हुए फल और सब्जी या फ्रोजन किए हुए, और बाद में कंज्यूमर उसको यूज़ कर सकते हैं। तो ये एक सिंपल मेथड है, इनोवेटिव मेथड है जो कि किया जा सकता है। और नेक्स्ट जो हमने सजेस्ट किया है प्रमोशन ऑफ किचन गार्डन। और आपने सुना होगा कि पढ़ा भी होगा कि भारत सरकार ने इस मंथ में नेशनल न्यूट्रिशन मंथ के पहले सप्ताह, मतलब 1 से 7 सितंबर इस महीने में का बताया है कि पोषण वाटिका, किचन गार्डन या हिंदी में बोलेंगे पोषण वाटिका लगाने के लिए, जो कि घर पे भी लगा सकते हैं हम, फल सब्जी उगा सकते हैं। इवन हॉस्पिटल, आपके इंस्टीट्यूट में मैं आई एम श्योर अगर कुछ जगह होगी, गार्डन होगा, फल सब्जी उगा सकते हैं, उसका आपके स्टाफ के लिए, आपके मरीजों के लिए, सबके लिए यूजफुल होगा। तो आप जहाँ भी हैं, हमारे वर्क प्लेस में, घर में, स्कूल में, यूनिवर्सिटी में, जहाँ भी हम काम कर रहे हैं या रहते हैं, वहाँ ये किचन गार्डन लगाए जा सकते हैं। इसमें ज़्यादा खर्चा नहीं है और इससे हमारा फल सब्जी का उत्पादन बढ़ेगा और कंजम्पशन भी बढ़ेगा। नेक्स्ट इज इंक्रीज कंजम्पशन ऑफ मिलेट्स। बहुत सस्ते होते हैं, जिसमें जब प्रोटीन की, आपको पता है जब लास्ट ईयर की गाइडलाइन आई थी कि अभी प्रोटीन और कार्बोहाइड्रेट का रेशो काफ़ी बढ़ा दिया गया है, 3:1 हो गया है। तो इसलिए कंजम्पशन ऑफ प्रोटीन डाइट बढ़ाना है हमें डाइट में। उसके लिए जैसे ज्वार बाजरा है, ज़्यादा महंगी भी नहीं है, इसका कंजम्पशन बढ़ाया जा सकता है। इसके लिए अच्छे अच्छे मेन्यू भी आप लोग सुझा सकते हैं। और क्वालिटी ऑफ डाइट्स को कैसे बढ़ाया जाए, भाई सिंपल टेक्निक्स है, जैसे आप सब जानते हैं, जर्मिनेशन, अंकुरित करना, जैसे हम चने को करते हैं, दालों को करते हैं। फर्मेंटेशन, उसको उससे जैसे हिंदी में बोले किण्वन, फर्मेंटेशन से सॉरी। डाइट डाइवर्सिटी, यूजिंग डिफरेंट टाइप्स ऑफ ग्रेन, एक ही ग्रेन ना खाएं, डिफरेंट टाइप्स ऑफ होल ग्रेन खाएं, डिफरेंट कलर के फल सब्जी खाएं, कभी हरा खा लिया, कभी पीला खा लिया, कभी लाल रंग का खा लिया। तो डिफरेंट टाइप के फ्रूट वेजिटेबल खाने से उसके जो डिफरेंट उसमें केमिकल प्रोडक्ट हैं तो वो हमारे अंदर जाएंगे। और कुकिंग ऑयल भी इस तरह से चेंज करते रहिए, यह नहीं कि एक कंपनी का ही ऑयल आप हमेशा यूज कर रहे हैं या खाली मूंगफली का तेल ही खा रहे हैं या सरसों का खा रहे हैं, तो आप चेंज करते रहिए। और लास्ट बट नॉट द लीस्ट, जो डाइट की क्वालिटी कैसे बढ़ सकती है, यूज ऑफ फोर्टिफाइड फूड्स, जो कि पिछले सालों से भारत में हो रहा है। सबसे पहले तो नमक से शुरू हुआ, नमक में पहले आयोडीन डाला जाता था, अभी उसमें डबल फोर्टिफाइड कर दिया है, जैसा आयरन भी डालते हैं। इसके अलावा दूध और तेल को विटामिन ए और विटामिन डी डाला जाता है। और आटे में या राइस में कैन बी फोर्टिफाइड विद आयरन, फॉलिक एसिड एंड विटामिन। ये इन सिंपल तरीकों से डाइट, खाने के खाद्य पदार्थों की न्यूट्रिशन क्वालिटी भी बढ़ जाती है। और इसके अलावा इंक्लूजन ऑफ लोकल नट्स, कोई ज़्यादा महंगे नहीं है, लोकली जो नट्स हैं, जैसे मूंगफली है, और भी बीज हैं, स्पाइसेस हैं, हर्ब्स हैं, इंडिजिनस प्लांट्स हैं। विभिन्न राज्यों में अलग अलग तरह के प्रकार के प्लांट, पेड़ पौधे पाए जाते हैं, हर्ब्स हैं, कुछ स्पाइसेस हैं, उनको भी यूज़ करने से हमारे हेल्दी डाइट मिलेगा और हमारी इम्यूनिटी भी बढ़ेगी। और इसके अलावा कंटेमिनेशन ऑफ फूड, जो खाद्य पदार्थ का जो मिलावट है उसका भी कम करना है, भाई कम करना है। जैसे कि रिपीटेड रीहीटिंग ऑफ कुकिंग ऑयल, बार बार खाने के तेल को गर्म नहीं करना, खाना पकाने के तेल को गर्म नहीं करना है। और अप्रोप्रिएट टेम्परेचर पे खाना बने पके हुए खाने को यूज करना है। और लास्ट बट नॉट द लीस्ट, जो खाना बनाने वाले लोग हैं आपके जो किचन में, वो इंश्योर करें कि वो वर्कर्स के पर्सनल हाइजीन अच्छी है। कभी वर्कर के अगर हाइजीन, पर्सनल हाइजीन ठीक नहीं है तो खाने का कंटामिनेशन हो सकता है। ये सब बातों का भी हमें ध्यान रखना चाहिए। और इसके अलावा मेकिंग पीपल अवेयर ऑफ रिड्यूसिंग HFSS फूड, आप सब जानते हैं HFSS, हाई फैट, सॉल्ट, शुगर एंड फूड्स। इसके लिए इसको कम करने से ओवरवेट बट कम होगा, ओबेसिटी, हाइपरटेंशन, ब्लड प्रेशर की बीमारियां और नॉन कम्युनिकेबल डिजीजेस कम होंगी। और ये शायद काफ़ी लोग आप में से जानते हो कि FSSAI फूड अथॉरिटी ऑफ इंडिया ने पिछले साल स्कूलों के लिए एक कानून पास कर दिया है कि स्कूल के अंदर और स्कूल के 50 मीटर के आसपास ना तो ये हाई फैट साल्ट शुगरी फूड मिलेंगे उनकी कैंटीन में, ना कि उसकी पब्लिसिटी की जाएगी कोई इश्तहार या एडवर्टाइजमेंट के द्वारा। तो ये इस पे टोटल बैन है, तो आप लोग भी इसको जरा जानकारी रखिए। तो ये हाई फैट शुगरी सॉल्ट शुगर फूड नहीं खाना है, HF बिल्कुल प्रमोट नहीं करना है। और लास्ट बट नॉट द लीस्ट, मैं अपने थोड़ा ज़्यादा बोल गया, बस आखिरी पॉइंट मेरा है। द रिपोर्ट ने जो रिकमेंड किया है, आप सब जो हेल्थ न्यूट्रिशन कमेटी है, that there is a urgent need to create a cadre of public health nutrition professionals। एक पब्लिक हेल्थ न्यूट्रिशन प्रोफेशनल्स का एक सेपरेट कैडर, जैसे डॉक्टर्स का कैडर होता है, मेडिकल ऑफिसर कैडर हर स्टेट में, IAS कैडर है और इकोनॉमिक सर्विस कैडर है, तो ऐसे पुलिस का कैडर है, ऐसे पब्लिक हेल्थ न्यूट्रिशन का भी कैडर एक बनाया जाए जो कि डिजाइन करे और इम्प्लीमेंट करे न्यूट्रिशन इंटरवेंशन को, और न्यूट्रिशन पॉलिसी मेकिंग में भी जो अपना सहयोग दे पाए। पब्लिक हेल्थ न्यूट्रिशन का एक कैडर, ये भी हमारी रिकमेंडेशन है। इसको हमने नहीं कि रिपोर्ट हमने लिख दी है और वेबसाइट में डाल दी है, हम इसको आगे तक ले जा रहे हैं, कोशिश कर रहे हैं। नीति आयोग से हमारा वार्तालाप चल रहा है, तो इसमें टाइम लगेगा, लेकिन हमारी जो टास्क फोर्स की रिपोर्ट रिकमेंडेशन है, हम इसको आगे कार्यान्वित करने के लिए अभी प्रयास कर रहे हैं। और जस्ट टू कंक्लूड my comments, I would like to conclude my address wishing a successful and fruitful symposium today, and also requesting all the experts who have joined today and all the participants present to fully utilize this National Nutrition Month to create awareness about healthy diets, improved health, and thereby improving health and nutrition status of all people of the country and all over the globe. Thank you very much. Thank you.
Thank you very much, sir, for such an enlightening speech of yours. The key message which I could gather, and I think I will agree that all of you must have taken, that sir has really made it very clear that how we have to reponder, think upon, and make the practical use of food right from production till the plate. We have to minimize the wastages which are happening. As sir has told us that 40% of fruits and vegetables are wasted in our country. That's something which we really need to work upon. We had been raising our voice to, go for immunonutrient foods during this pandemic time, and we were wasting the immunonutrient rich foods. So we really need to work upon it. Thank you, sir. One more advice which you gave to all of us was that we have to start with, just a sec, Director ma'am has called. Just a sec. Good morning, ma'am. Hello. I'm really very sorry, but our director just got busy with the faculty interview, so she will be joining in. She has just conveyed a message. Sir has very nicely given all of us a very good insight that we need to promote not only the Poshan Vatika at home, but also in our campuses, whether it's school, it's hospital, or any institute, where these kind of, Poshan Vatika might help to give the supply to our employees, to our students, to our workers, and even to our patients. So this was very useful advice, sir, which we will really try to work upon and make it possible in our institute. And Dr. Anuja ma'am, thank you very much for introducing such a nice and enlightened person, the administrator who knows so much and who wants us to work on this. Anuja ma'am, are you able to hear me, ma'am? Thank you, ma'am. Thank you. Sir, Anuja ma'am was the, the connecting person who helped me to come. Okay. Thank you, ma'am. Thank you very much. Now, Ma'am, now I would request our guest of honor, Vandana ji, you're here. Can you hear me? Because, you know, Vandana ji, I really appreciate her efforts being in different time zone. She first told me that, Poonam ji, I'll be sending you a recording and the recorded message, but then somehow she had joined us. I just need to confirm if she's here. We can hear her on virtual platform. Vandana, are you there? Can you listen to us? I think now she's there. But I think, Vandana, I'm going to start with you. If you are comfortable, we would love to hear you in person. Okay, so our guest of honor, Vandana R. Sheth, RD, CDCES, FND, nutrition entrepreneur and medical expert reviewer at US News and World Report, Los Angeles, California. Vandana Sheth is an internationally recognized and an award-winning registered dietitian, nutritionist, certified diabetes care and education specialist, CEO of a successful nutrition practice that offers in-person counseling in the Los Angeles area, as well as on virtual nutrition coaching programs. She has over 2 decades experience and specialization in intuitive eating, vegetarian nutrition, diabetes, and family nutrition. She's passionate about having a positive impact in the world. As a strong proponent of diversity, she has served on the advisory board of Diversified Dietetics since the beginning, served as the diversity liaison for 3 years, the chair-elect for Indians in Nutrition and Dietetics Member Interest Group. She is the recipient of the 2021 Outstanding Nutrition Entrepreneur Award for the Nutrition Entrepreneur Dietetics Practice Group 2021. Outstanding Dietitian Award for California Academy of Nutrition and Dietetics 2020, Outstanding Diabetes Educator Award for California Association of Diabetes Care and Education Specialists, the 2016 recipient of Excellence in Business Communication and Private Practices for California Academy of Nutrition and Dietetics, as a national media spokesperson for the Association of Diabetes Care and Education Specialists and former national spokesperson for Academy of Nutrition and Dietetics. Her media appearances include the New York Times of Nutrition and Dietetics and Newsweek, the Washington Post, Forbes, Prevention, Consumer Reports, USA Today, ABC.com, EverydayHealth.com, iVillage.com, AOL.com, LA Times, Chicago Tribune's Newsday, Times, Today's Dietitian, Reader's Digest, Cosmopolitan, People, Paradise Cooking, Light, Parent Fitness, Parenting, Shapes. Oh my God, Vandana, you have a tremendous, experience on having, and apart from this, she's the published author of a cookbook, My Indian Table, Quick and Tasty Vegetarian Recipes. Thank you, Vandana, for taking our Indian cuisines at the global platform. So if you are here, we would love to hear directly from you. Otherwise, I'll play your recorded message. As you say, Vandana. I think she is not there. I would request Shreya to play the audio message of our guest of honor. Shreya, would you please play the slides of Vandana ma'am, which she has sent it on our recorded message?
Ma'am, just a second, I'll play.
please bear with us for these technical glitches. We had been trying hard to make the things possible, and just give me 2 minutes time. We have got this recorded message, and very soon we will play this message, which is very enlightening and helpful for all of us. Just give me 2 minutes time. Thank you.
Oh, thank you so much for inviting me to the conference. I am so excited to be here, and I wish I could meet you all in person, but appreciate the opportunity of presenting to you virtually. Welcome to my home office, which is our backyard today in Los Angeles. Someday, I hope to meet you in person. Thank you to the planning committee, and I welcome all of you to the International Virtual Symposium organized by the Department of Dietetics of Dr. Ram Manohar Lohia Institute of Medical Sciences. Thank you again for having me here. When I was asked to present, I was wondering as to what would be interesting and intriguing to all of you. I came up with 3 simple talking points. The first is that I'd like you to spend some time with reflecting on your brand. What do I mean by brand? By brand, I don't mean the color or the logo or anything like that. I'm talking about you. What made you go into this field of nutrition and dietetics? What drove that passion? It's important to spend some time reflecting on this, regardless of whether you're an entrepreneur like me or if you work for a university or you work for an organization. It's important to identify your brand, your unique perspective, because that is going to drive your passion in all your interactions with clients, with patients, as well as with any articles that you might write. That is your voice. That makes you stand out. So I encourage you to spend some time reflecting on your brand and what makes you unique. The second part of my talk is about awareness. As healthcare providers, it's really important that we stay on top of cutting edge information. And so we need to keep track of trends. And that's because our clients, our consumers are keeping track of trends as well. I know it's September, so we're quite a few months into 2021, but I'd still like to go over some of the top trends that we've noticed in 2021. And please keep in mind that this is based on surveys done with people in the United States, but I know it's a global world. We are all communicating virtually with people all over the place. So some of this will reflect with your clients and your patients as well. The first trend that we're noticing is that because of the pandemic, what's been happening is people are much more focused on their health and how good nutrition can impact their quality of life and longevity. The 2 parts of this are immune health and gut health, and people are definitely interested in more of these 2 topics. So I encourage you to write more articles, to be part of a conversation where you can address these 2 areas because there is a demand and interest. The second trend we are noticing is that with the pandemic, what's happened is people are definitely on a very tight budget. They're much more value conscious. There's been a lot of financial hardship. So when you make recommendations, I encourage you to choose products, choose foods that are budget friendly, that can service our clients at all different budgetary levels. The third trend we are noticing is that comfort is important. So especially with mental health and well-being, comfort food is something we are drawn to. Just as a quick story, I remember when the pandemic first hit us here in Los Angeles, when you'd go to a grocery store, literally the first things that were gone were things like bread and pasta and mac and cheese. And I'm sure this sort of situation happened in India too. So people are looking for comfort foods because they make us feel good. What I'd like to suggest is that you look at your clients' requests and see what they would like to eat and come up with simple tweaks so that they can enjoy their favorite comfort foods, but healthify it a little bit with your guidance. The fourth trend we're noticing is that snack type meals are here to stay. Rather than having just breakfast, lunch, dinner, people are trying to snack a lot more, and those snacks become meals. Now, this trend is here to stay, even if people are going back to work. So if this is something you're seeing with your clients, it might be a teaching opportunity for us. So we could help our clients choose foods that are snack-like, but that also meet their nutritional needs. Maybe something with lean protein, pair it with something that's a high fiber carb, add some heart-healthy fats, and right there, it's a snack, but it also can be a meal because it's hitting those targets. The last thing we're noticing as a trend is social media. Our clients, our consumers, our patients are looking for information, especially through the pandemic, to social media for answers to their questions. And so I encourage you to please have a social media presence. Be part of communities, have engaging conversations, because you can be the voice of reason. There's all kinds of myths out there, and we want to be the voice that can dispel some of those myths. So I encourage you to have a social media presence so that you can have that impact you want. The last part of my presentation is about the theme of this topic. You are all extremely qualified. You are professionals. You have a lot of education behind you. But all of that science-based, evidence-based knowledge does not create the impact for our clients and patients unless we're able to translate that information into easily understandable, practical solutions. So we need to translate our science-based message into tips that can reflect on their plate, on their thali. So for example, if you have someone with diabetes, rather than talking about grams of carbs, you can simplify to how many rotis or how many cups of rice or how many idlis, and right there you've made it more applicable. I also encourage you to come into your client interactions from a place of curiosity. I know you deeply care about your patients and clients, so let's show that by being part of a team. Let's collaborate with our clients. Help them make decisions for themselves with the right knowledge and guidance so that they can apply this information to their lives. They can change, modify their favorite traditional recipes into a way that's healthy and still that tastes good. So I wish you all a wonderful conference, and I really appreciate you having me here. Thank you again so much for inviting me. I hope you found this helpful, or at least you found some part of it interesting and you can take action. I would love to continue this conversation, so please stay in touch. I am on social media. You can find me on Instagram, Facebook, and Twitter. I'm also on email, of course, so please reach out so that we can continue this conversation. I wish you a wonderful conference. Thank you again for having me. Namaskar.
Thank you, Vandana. Thank you for such an enlightening message. And this goes very well with our topic, therapeutic nutrition from theory to plate. Thank you very much. Thank you for this message. You made certain things clear, which we all had been talking and we all think in the same line. That is, rather than emphasizing more on the grams, carbs, and the various technical terms nutrition field, we should rather explain our patients in the more understanding way. Thank you, Vandana. Thank you once again for your sweet message. And it really helped us a lot. Thank you. I would request now Dr. Vandana Bhandari to please take up the last part of our session, that is the vote of thanks. I'm really thankful to Vandana because she had been the support who had been helping me online, getting people in touch, and she being my junior, and we all had been sharing the same alma mater. So thank you, Vandana, once again, and over to you. Thank you, Vandana.
Thank you so much, Poonam Di, and it's indeed an honor and privilege to be sharing the platform with such luminaries. And please do not thank me so much. It's my pleasure, and I'm so glad I could be part of this virtual symposium, which is so relevant in these times. And as my duty, today, I have been designated to give the vote of thanks, and I would begin by saying thanks is but a very small word for everybody who's present here for this symposium. Greetings to all of you. a very happy National Nutrition Month 2021. I would begin with expressing our deep sense of gratitude to the chief guest for today's symposium, Dr. Saxena. Thank you so much, sir, for enlightening us by your wonderful lecture, which elucidated small but significant innovative ideas that can make an impact in the field of nutrition and take forward the culture of theory to plate, farm to fork. Thank you once again for your presence here, for sparing your valuable time to be with us and enlightening us. I would be failing in my duty if I do not acknowledge the presence of our guest of honor, Vandana Sheth. Miss Sheth, you've made this symposium so global, as they say, it is a global symposium, and with your practical, approachable tips as to how young dietitians, entrepreneurs, nutritionists can make a difference in the lives of their clients and patients. And I would resonate your thoughts, as would the other participants in this conference, that we all deeply care about our clients and patients, and therefore we try to do everything we can to make their life healthier and happier. Thank you once again for your very crisp and engaging message. Thank you for joining us from the US and sharing your knowledge with us. I would also like to thank Director Ma'am, Professor Nityanand. We miss your presence here today, but we hope to hear you soon. Also, thanks and gratitude is in order for our Dean, ma'am, Professor Husain. As I can gather from the conversation today, you were a spurring force behind organizing this symposium and taking it to greater heights. Thank you so much for your message. And we are so grateful for your presence in our lives and the Institute. This conference would have been incomplete without the presence of our wonderful keynote speakers. And I'm sure all the participants would be eager to hear the keynote speakers as they share their treasure trove of knowledge with us. Thank you so much, Ms. Agarwala, for all your inspiration, and we really look forward to hearing you soon. Thank you so much, Dr. Jayatissa, who's joining us all the way from Sri Lanka. Jayatissa, I'm sorry, who's joining us all the way from Sri Lanka. And we really look forward to hearing you too. Thank you for accepting our invitation. A big thank you to all our speakers. Dr. Madhu Sharma, we are so fortunate to have you with us in this symposium. We really look forward to learning so much from you. Thank you so much for being here. Mary Murphy, who will be sending us a recorded message from the US. Archana Sinha, Dr. Smita Singh, Preeti Soni, Sabha Umar, Prachi Chandra. So this is a wonderful lineup of speakers we'll have for today's symposium. Thank you so much, everybody. We look forward to hearing you. And now comes the time when I've been waiting for this, to thank Poonam Tiwari, the force behind this symposium. You have been working round the clock, as acknowledged by our eminent speakers too. And thank you for all the hard work, for your lovely smile, for being here. And we're all trying our bit to make a difference in the field of dietetics and nutrition. So thank you so very much.
Thank you, Vandana. Thank you. Extending Vandana's note of thanks. This Thanksgiving thing will be incomplete if I don't recognize the efforts put in. Ideas could be there, but the backdrop help is one thing which makes the event possible. So in that backdrop help, I have my dietetics team, Ms. Shreya Chaube, my assistant dietitian, Rubia Firdaus behind the technical designing of the brochures and the other things. And then Anukriti Verma, she is there as an assistant dietitian. They all had been, rendering their unconditional support to me and to the whole, making this conference possible. I'm really thankful to our IT department, Akhilen Verma ji, for helping us to meet with the technical issues in this virtual platform. Thank you, all of us. Thank you to my participants who really came up and who made this event possible, because without you, we are nowhere. So thank you very much for joining the session. And I wish that we all will have a very informative and knowledge sharing session and an intellectual treat for all of us today. So let's start with our next session. That is, we are going to start with our scientific session now. I would request all these speakers and our eminent chief guest, sir, to just switch on your video mode so that we can have a snapshot together. And that would be a wonderful thing if we have that. All the speakers, if we can be there on the screen. I would request Shreya to just stop sharing screen so that we can have a snapshot of all these speakers all together. Smita, may I request you, Sabha, Smita, Madhu ma'am, Renuka madam, all those who have joined right now. I understand Prachi, Archana, all of you, if you have joined in, please do be with us so that, oh, Vandana, that's great. We would love to hear you. I played your recorded message. I played it and I was thinking that we could hear from you. So before that, I would request you to say a few words. Thank you, Vandana.
Well, you have an amazing conference. I loved listening to Dr. Saxena and Poonam. Your energy is so exciting. I can't wait to listen to all your speakers. So thank you again for having me. It's just so wonderful to connect internationally. I see a dear friend, Preeti, is going to be representing California soon. So that's wonderful. But thank you again for having me. I think you're all doing some amazing work. I was so fascinated by the nutrition policies that Dr. Saxena mentioned, like the kitchen gardens. I think that's fantastic. We do have kitchen gardens in hospitals here that the staff can enjoy, farmers markets, things like that. So I think that's wonderful that you're having it. So thanks again for having me. I look forward to someday seeing you all in person. And
yeah, we need you for, thank you very much. We need you for a snapshot. So all these speakers who are here, and if they can be there on the screen, so I can request Shreya to just take a snapshot of all our speakers here. And it's wonderful. So all the very best for our coming conference. Anuja ma'am, all of you are there. I'm really thankful. Madhu ma'am, thank you very much. Thank you. Thank you. Okay. Thank you, sir. Thank you, Pradeep, sir. Thank you very much for your enlightening speech. Once again, we now move forward to our scientific session 1, where we will be having our keynote speaker, Anuja Agarwala madam, who is going to discuss a very, very interesting topic, which is very fascinating. You know, we really need to understand the difference between therapeutic nutrition and clinical nutrition. Hello, Renuka ma'am. Thank you for being there. Good morning. Thank you for joining us over from Sri Lanka. Thank you, ma'am. So that's wonderful. So now, beginning with our keynote speakers, I would now ask Vandana to take the session chairperson position so that we begin with our scientific session. I'm really thankful to all of you. Over to you, Vandana.
Thank you so much, Poonam. So it's really a pleasure to be introducing our keynote speaker for the first session, scientific session for today's conference. And it's indeed an honor to have Ms. Anuja Agarwala with us. Thank you so much, ma'am, once again, and we really look forward to hearing you. She would be speaking on therapeutic nutrition versus clinical nutrition challenges and solutions. Ma'am has over 30 years of experience in the Department of Pediatrics, AIIMS, with a fellowship in Pediatric Nutrition from Birmingham Children's Hospital, UK. She's a certified genetic metabolic dietitian from the British Dietetic Association, UK, member of Genetic Metabolic Dietitians International, USA. Her special areas of interest lie in juvenile diabetes, dietary therapies in epilepsy, nutritional therapies in genetic disorders, pediatric gastroenterological disorders, particularly celiac disease. A list of achievements are absolutely humongous, and we just have a small glimpse of them here. She's a scientific panel member and technical advisory committee member of FSSAI since 2008. She's a partner with FSSAI in Diet for Life initiative to spread awareness about genetic disorders, expert committee member in government projects and panels, e-working group member of Codex Alimentarius. She's co-authored Nutrition chapter in Essentials of Pediatrics, textbook for M.B.B.S students edited by Dr. V.K. Paul and Dr. Arvind Bagga from AIIMS from the 7th, 8th, and 9th editions. She has original research publications numbering 40 in national and international journals with a high impact factor. She's involved in many funded clinical nutrition as well as community-based research projects. She's a co-investigator in thesis of DM, MD nursing and dietetic students. So once again, I extend a very warm welcome to you, ma'am. Thank you so much for gracing this platform, and we look forward to hearing from you. Over to you.
Thank you so much, Avantina, right?
Yes,
Thank
absolutely.
you so much. And I'm so honored to have been given a chance to speak on this platform. And at the outset, I would like to thank all the organizers, particularly Poonam, who has organized this international symposium conference for today. So, Poonam, will you be sharing my screen, or should I do on my own?
Ma'am, the way you're comfortable. We had just collected it. Ma'am, if you want, you can also. Shreya, can you please help ma'am? Can ma'am share her screen, or you are going to do that?
Most disabled participant screen sharing. So, if you can share, that's fine.
Okay, ma'am. I will share.
Right. So just one more quick note. We would take all the questions at the end of the session during the panel discussion. So participants, please note down your questions and we will take them at the end. And the same goes for other speakers for the session. Please let us know if you would like to share your presentation or would like us to share it. Thank you so much.
Shreya, I think ma'am would like to share on her own. So can you facilitate ma'am to share her screen? Is it possible from your end, Shreya?
Yes, ma'am.
So please facilitate ma'am to do that, please.
Okay, ma'am.
So yes, I got it. So I can share it. Right. I hope all of you can hear.
Shreya, you need to stop sharing your screen because we want to see ma'am's screen now. Shreya, you have to stop sharing your screen so that we can see ma'am's screen. Yes, ma'am, we can see your screen now. We can see your screen.
Right. So you can hear me too?
Yes, ma'am, we can hear you. You're audible.
Right. So, so as I said, I'm very honored to be here and presenting you the very tough topic. Actually, when I was researching about this, I actually put down on our group that we have never thought, is there a difference between therapeutic versus clinical nutrition? We always focused on therapeutic nutrition while we were in college, right? And the term clinical nutrition was very, very used very, very sparingly. We hardly use the terms clinical nutrition. This topic, as I go on, is a little controversial, but it does does take out a lot of challenges. It does have a lot of challenges for the dietitians today. So it's not a subject, which is therapeutic nutrition and clinical nutrition. These subjects, actually knowing them, how it is implemented by the dietitians, and that is the one which causes challenges. And there's where we have to find solutions. So for therapeutic versus clinical nutrition, is there a difference? So let us first see a few definitions, which are very simple, and all of us know that eating healthy and balanced diet definitely improve our quality of life. And we've heard from Dr. Pradeep Saxena as well. And now when India has such a high rates of stunting and wasting and undernutrition, this is one thing that we have to focus about. In last 2 decades, you've been talking a lot about healthy, balanced diet, and what is a boon to us is the book that the ministry has taken out under his guidance. Then poor diet may also, we know that the poor diets will lead to morbidity and other mortality and other disease conditions, and so many serious disease conditions. And we see today in the public health arena, so many of them, non-communicable diseases, and now the infectious diseases have also come in. Then as we describe diet, feeding individuals, this is defined as feeding individuals the impact of food on human health based on the principles of nutrition. So basically dietetics is feeding the individuals in terms of food, converting and translating the principles of nutrition. While nutrition is a branch of science that deals with nutrients. So that educates us about a lot macronutrients, micronutrients, and whole lot of trace elements and all that. It is about eating a healthy and balanced diet, which is translated into food, and that is called dietetics. What I understand from therapeutic nutrition, that it is, something which gives us supportive care to treat the disease conditions, or maybe advising a normal healthy diet to an individual. So this is, as we talk, we have always heard art and science of human care. So therapeutic nutrition deals more with the art side of human care. It is about counseling and convincing a patient to eat, and that also need a lot of tact and skills. So as we are working in the hospital setup, or we are working in different setups, and maybe you are an independent consultant or a nutritionist, counseling, we all know they are disease specific counselings. They cannot be just one way of counseling. There are so many different ways of counseling, and we learn the skill of counseling as we get experience in this area. We have to explain it in a simple manner to our patients. We have to, it also involves modification of a normal diet to a specific health condition. For example, if we are doing something, advising a diet to a diabetics, it is not just about advising a diet chart. It is about telling them a little bit about disease and connecting it with the diet. So it needs a lot of, knowledge about diet as well as disease. So it is about qualitative, rehabilitative, and corrective and restorative kind of, art, deals with art side of this. Having a healing effect, therapeutic means having a healing effect. For example, somebody says therapeutic dose of medicine. So it has a healing effect. It tends to make a person healthier and tends to make a person happy and relaxed. It is definitely based on the general principles of nutrition and application of nutrition as a therapy or intervention for the symptom relief or recovery. So what is clinical nutrition? Isn't that clinical nutrition as well? Let us see. First of all, I would like to emphasize on what are therapeutic diets. We have all learned in our college that is used as a treatment and condition to eliminate or decrease certain, we either tend to increase or decrease certain foods or compounds in the diet. For example, if you are, somebody is a celiac, we are advising a gluten-free diet or lactose-free diet. we are advising regular diet. These are some of the kinds of diets which are popular diets in the hospital setting, like soft diet, liquid diet, diabetic diet. So, so what is the clinical nutrition side of it? Clinical nutrition is synonymous to medical nutrition therapy, and it is the science of human care. So they both are quite overlapping if we talk of therapeutic as well as clinical nutrition. And that's why we say we deal with art and science of human care. But clinical nutrition essentially deals with understanding of pathophysiology, disease affecting the nutritional status and its parameters, correlate with the cellular biochemistry. That means it is more in-depth knowledge of nutrition. So it is medically prescribed diets, and diets are highly individualized meal plans, for the specific patient and with a precision. As my introduction also says that, my interest is in the ketogenic diets and inborn errors of metabolism. Let me tell you, the diets which we plan, we need to have a solid knowledge about biochemistry, metabolism. What is a biochemistry telling us? The bloods are telling us, what is the genetic reports telling us? And accordingly, we plan a diet with a lot of precision, and it is a personalized kind of a diet. So specialized oral feedings, enteral nutrition, intravenous solution, whatever you may say, all of this requires a lot of thorough knowledge about pathophysiology and the condition. The ABCD, which we used to learn in our colleges, like A for anthropometry, B for biochemistry, C for the general condition, the general history of a patient, and D for dietary recall or dietary assessment. So adjustments are made based on the food or nutrient or interaction. So we must have a knowledge of food and nutrients and what is their interaction with each other. The in-depth nutritional assessment, as I said, determination of nutritional diagnosis, which is very, very important. Medical diagnosis is one thing, but nutritional diagnosis is what is going to be made by the dietitian. And that is a clinical nutritionist who makes a nutritional diagnosis. Implementation or tailor-made nutrition intervention for the individual or the group, and which is with precision and personalized, as I already said. Periodic monitoring of these patients are important. Then evaluation and reassessment and revised intervention are there to actually manage the patients and prevent a disease or injury or trauma for a long time for these patients over time, right? So, and as I said, this is just in a nutshell saying we need to do nutrition screening. A dietitian or a nutritionist does a nutritional assessment, nutrition diagnosis, and this is done by the clinical nutritionist who is a registered dietitian or a nutritionist. In Western countries, there's another term which is also very popular, that is NDTR, which is Nutrition and Dietetic Technicians. I'll talk a little bit about that in my later talk. So let us see what is the practices in India, and that is a real challenge. And what is the status of therapeutic or clinical dietitians in India? Because I've already said in a nutshell what is the difference between the subjects, which is called therapeutic nutrition, and the clinical nutrition. But these subjects are going to be read by the dietitians and implemented by the dietitians. So do we practice therapeutic nutrition or clinical nutrition? The majority of us, the answer is we practice therapeutic nutrition, yes. Not clinical nutrition. Very few of us, I would just say we have come a long way, though. I am not being, being pessimistic that none of us use, all these nutritional assessments and then going over to monitoring and reassessment and all that. A lot of us are doing it, but most of us are doing therapeutic nutrition. And I must say, when I talk about it, I always say most of us. I repeat by saying yes, us, because I belong to the same fraternity, and I have also been using therapeutic nutrition in my practice. But somewhere down the line, I realized I have to become clinical nutritionist, which is not actually taught to us so much in India. As I said, in our curriculums, clinical nutrition, therapeutic nutrition is used mostly rather than clinical nutrition. So what is therapeutic nutrition? What do we do? And if I say the majority of us practice therapeutic nutrition, that means nutrition plans are instructed. Till today, I know that the instructions are written that plans such and such diet, so many calories. The consultations are sent to the dietitians saying that we need this diet with providing so much calories, so much protein and all, or telephonically to what is, and they are expected to follow. So dietary intake, the kind of diet, energy and protein which is to be prescribed are often told by the physician.
Excuse me, ma'am. Please, Lupur Chitranshi ji, please unmute yourself. It's disturbing a little bit. Please unmute yourself. Mute yourself, please. Ma'am, we are not able to hear you. Ma'am, please unmute yourself, ma'am. Ma'am, please unmute yourself. We are not able to hear you, ma'am.
Yeah, can you hear me now? Hello?
Yes, ma'am. Yes,
Yes,
ma'am. Now we can hear you.
Thank you.
Yeah, yeah. So just let me make it full screen. Yeah. So as I was saying that most of us, what is a practice of therapeutic nutrition? The practice of therapeutic nutrition, and most of the dietitians doing that, is that nutrition plans are often instructed by the physician, that plan such and such diet, plan so much of energy and protein, provide so much of energy and protein to the patient. And consultations are often sent, written consultations, and the dietitians are supposed to come and see the patient and prescribe the diet and talk to them whatever is being told to them. So structured diet plans are already there. They have to make a little bit of a modifications in the diet. For example, diabetic diet, no matter whatever kind of insulin regimen is there, no meal, no carbs counting is done, and the structured diet charts which is available are modified and given to the patients. This was, I'm not saying that we've not come a long way. As I said, a lot of us are now doing clinical nutrition, but most of the practices like this. Skeleton diet charts are different energy and protein values are there, modified as per instructions on the patient's file and OPD cards. So upgradation as a clinical nutritionist is often done on the job training. We do not have any training, in-depth training to upgrade us as clinical nutritionists. So we don't have the provision of CPD, which is continuous professional development courses with credit points given to us, and continuously we are supposed, it is not mandatory for us to upgrade ourselves continuously for the clinical nutrition trends, and that's we continue, most of us continue to practice like a therapeutic nutritionist. So also that most of the dietitians are pushed to the kitchen related matters. And some of the times I've seen that's an intentional choice also. So they basically, their major focus in ordering food, indents, recipes, food options, instructing cooking and doing the meal planning. I'm not saying that's not important, but then if you want to be a clinical nutritionist, you can do just one thing. Either you are an institutional food manager or you are a clinical nutritionist, because both are very time consuming. Dietary services mostly posted under HR and MS. They are services. They are not the department to run the hospital kitchens. And they are professionals, institutional food administrators, professionals, hospital. Now, you know, we have a lot of good hospitality services. There are a lot of private people who have come in who provide services at the outsource. You know, they are outsourced to those agencies and they provide these kind of services rather than dietitians. And there is their responsibility, or if the dietitians are responsible for running the kitchen, they have to provide safe and quality food, and they have to do food procurement, manage the hospital kitchens, versus what is clinical nutrition departments. There are a few departments, are they available in our country? There are a few clinical nutrition departments which actually essentially run under gastroenterology departments, or which essentially have PhD in nutrition, and a majority of them are all clinicians, which their primary role as clinicians are to initiate specific nutrition related researches, rather than doing actually practicing clinical nutrition. So there's super specialty medicine also, but there are no nutrition teams. So these are the problems and challenges. We have not been able to create clinical nutrition teams. So clinical definitely is a facility-based area. We have public health nutrition, which is community-based, but somehow, because probably we have so many public health problems, it takes a priority and they are treated superior. But should they be integrated, right? In Western countries, if I speak, the dietitian who is dealing with a patient in the hospital, right? The patient definitely has to go back to the community, and there is a link between the dietitian from the hospital to the dietitian in the community. And this particular child or a patient coming to the hospital is taken care in an integrated manner, so that he doesn't keep on coming back to the hospital. So where is the, how is this challenge of public health nutrition be sorted out? I think we need to get integrated. And there's nothing called superior or inferior, but somehow, you know, clinical nutrition in the hospitals are not given that much of importance. So there's a huge challenge, and why there is a challenge with the clinical nutritionists today, because do our curriculums really teach clinical nutrition? Really no. Because if you look at the, you know, medicine courses, they are, you know, within the hospital, they read and they practice in the hospital. So while they're learning something from the courses, whatever, I mean, I know I take classes for the M.B.B.S students on nutrition when they are posted in 4th semester in the OPDs. They are supposed to take a dietary history, and so we teach them how to take a 24-hour recall. When they come to 6th semester, they're supposed to make a normal chart for a normal healthy individual. So we teach them how to do a
नहीं यार वो काटोगी तो सर्टिफिकेट नहीं मिलेगा.
I request all the participants to stay muted and only the speaker. Miss Asia Hashmi, turn off your mic.
चलो क्लास करें. देवीना मैम कौन बनेगा?
Miss Asia Hashmi. Can I request the IT team if you can facilitate muting? Thank you. And I once again
Right. So can you hear me? Hello.
Yes, ma'am, we can hear you. And so sorry about that. Thank you.
So this is again, as we are talking with therapeutic and clinical nutrition, I'll be a little critical about dietitians. Why there is a, I'm not offended, but I'm just telling you the fact, why there is a race for just taking a certificate and not paying attention towards what you are attending. I'm so sorry, and that is where we fail. And I'm a part of the whole fraternity. So this is really sad. So coming back, do our curriculum really teach clinical nutrition? No. And so many of our teachers may get offended, but that is not the clinical nutrition we actually practice in the hospital. When I first came to the All India Institute of Medical Sciences, I actually had to relearn everything because there was no connect between the theory and the practice. So there's so much of heterogeneity of the course content throughout the country. Focus on therapeutic nutrition is there, but the focus on clinical nutrition can only come if it is integrated with the hospital or integrated with the medical science and medical education. We also now have choice-based subjects. Do M.B.B.S have choice-based subjects? If we make it choice-based, any healthcare subjects or any healthcare course, then it doesn't do justice with clinical nutrition. Duration of the courses also vary. Food nutrition and dietetic courses offered under a variety of names throughout the country under various universities have nothing to do with clinical. So there are online courses. Can healthcare be taught online? You can do upgradation, once you have done your graduation and post-graduation, which is as a regular person, and you can do online courses to upgrade yourself. But doing a graduation and a post-graduation or online course and saying that you're a clinical nutritionist, I don't approve of it, right? Then Indian nutrition clinical protocols, guidelines for various diseases are not there. They are not available. Most of the time, of course, SAM is there, and that's been there for more than 10 years now. We have diarrhea protocol that's been there, but where are these protocols created? They're all created in the big hospital like AIIMS by, with the help of WHO, Indian Academy of Pediatrics, but where the diet, clinical nutrition research and trainings are very, very inadequate. So how do I go forward? Yeah. So we need a drastic change in our curriculum with clinical orientation. That's really very important. We need to integrate with medical science and education. There has to be a uniform course with the same name. Does M.B.B.S have different names pan-India? It has the same name. We have to have the same duration of the course and content pan-India. We need the introduction of CPT workshops and take credit points. It should have to upgrade our knowledge and skills, and that should be made mandatory for everyone. Otherwise, they should not get a registration in the as a nutritionist. Specific trainings in super specialist areas of diet and nutrition are required because our medical sciences actually upgraded themselves to super speciality. So there is a need for a super specialist dietitians, but we are not there. Quackery and mockery of nutrition, there are self-styled nutritionists who are doing that. They are low quality standards. So we need to have quality standards. We have to have, we have to also see that today there's somebody in PhD in food technology, they're nutrition academicians, they also upgrade themselves. They also call themselves dietitians at times. That cannot be allowed, because to become a clinical nutritionist, they cannot become clinical nutrition automatically. There has to be a mandatory internship RD certification and registration. Nobody can say that I'm a PhD in nutrition, so I can be, waiver off my internship and RD certifications. No, it should be made mandatory. Strict regulatory body of the government is required, and that is called Council for the Allied Health Council, and the government today is working on it. One dietitian, today we see the status of dietitian, one dietitian for 100 and 200 bedded hospital. They're perceived as good meal planner rather than clinical dietitians. So obviously, if her duty is, she's a service duties towards the kitchen, and she is on service and posted under the HR or superintendent and services and all that. So her main duty actually becomes, looking after kitchen and the meal planning and the procurement of the food and see the quality of food. Where is the time to do clinical nutrition? And if she's supposed to do all of this, then it is too much of work. And what does she get? Her pay scales are very low. So that is a sad part. One patient will require minimum half an hour for a clinical dietitian or nutritionist for intervention. And in a government hospital, and frankly, my hospital could be very different from other hospitals. And in a day, in a specialty clinic, I could be getting anywhere between 30 to 40 patients, which runs for only 4 hours. So you can imagine how much of counseling one has to do, how much of time spending one has to do. So she will not, if you want to upgrade yourself as a clinical nutritionist, you don't have time for other things. Is there a need for clinical nutrition? Yes, definitely we have a need. Even medical professionals feel so. There's a very urgent need of clinical nutritionists. Is there a difference or definitions or terminologies? There's a whole lot of confusion between dietitians and nutritionists in India. It's not defined. There's no definition. ICDA, I'm not sure how many countries are there under ICDA. India is also one of the members of International Confederation of Dietetic Associations. And the terminology which they have given for dietitian and dietitians as well as they have not defined it separately. They use it synonymously, and they call each and every dietitians or nutritionist as dietitian nutritionist. That's the terminology they have given. We have also proposed to the council in India, let us see, because everything is in India will be debated before it is taken into consideration, and it is also it will also be shared in public domain for comments. So I'm not sure whether India will take this terminology or not. Most of the Western countries have taken this terminology. So IDA at the moment is not approved, Indian Dietetic Association. Before it goes to the regulatory body, opens for discussion and consensus on the decision. So we have a lot of self-styled dietitians, synonymous to, what I want to say over here is dietitians in India is seen synonymous to, weight reduction. Anybody who can suggest a weight reducing diet or suggest a dieting, the phrase is interchangeably used, such as dieting chart, dietitian chart. A lot of professionals, healthcare professional also comes and they come and say, can I have a dietitian chart? So can you imagine, they are not even used correctly. A dieting chart, a diet chart is the correct word. What is a dieting chart and a dietitian chart? I fail to understand. So a lot of healthcare professionals also use it wrongly. So we need to define our terminologies very well. So there's the belief and perceive that dietitians only are there for restriction of the diet, but that is not a fact. Nutritionists in our country are considered superior. And who are nutritionists? They're supposed to be academicians, public health professionals, even food technologists are nutritionists, food scientists who have nothing to do with counseling. Actually, food scientists are the agriculturalists. They are not working in the hospitals or suggesting diets and everything. They call themselves nutritionists. Somebody who's done PhD, they call themselves a nutritionist. And at times I feel they feel that it is below their dignity to call them dietitians. Why is it so? So I think dietitian's job is equally very, very important in a clinical setup. So, and those involved in nutritional research, they call themselves nutritionists. So in a way, I have an incident with you that some time back, we said that our association, Indian Dietetic Association, should also have a terminology of nutrition. Somewhere we should include in our name nutrition as well. And somebody turned around and said, "You are not nutritionists." So that is very hurting at times. So what is the difference? It is not even defined. So people have become self-styled nutritionists as well as dietitians. So our work profile and job descriptions as a nutritionist or a clinical dietitian are different. Where is the question of comparison? So I've not understood. So we do face a lot of challenge. So let us have a look at Western dietitians and nutritionists. So a Western dietitian is a licensed healthcare professional who is registered. They get a university degree, including courses in nutrition, dietetics, and they go through an internship. There's a separate test for a practicing dietitian to register herself. And for that test, they have to do additional studies. So they are legally and professionally, then they're able to use the term RD after their names. The RD works in the hospital, nursing homes, as a GP in medical nutrition teams with the physicians. And they prescribe specific diets, foods, and nutritional regimens for various disease conditions. While a nutritionist in Western world is more variable and less precise. One could have, the basic degree in nutrition science and call themselves nutritionist. They may be just nutrition literate people who can call themselves a nutritionist. They are able to provide nutrition advice. They are restricted to provide nutrition advice. They can't provide nutrition advice, because they are not RDs. They're allowed advising healthy people only. They could also do nutrition research and call themselves, one can also do nutrition research, upgrade themselves and call themselves nutritionist. They're also nutrition therapy practitioners. So for that, they have to take additional certification. With NTP certification, one can legally prescribe nutrition advice, while nutritionist with basic qualification cannot advise diets. So also nutrition and dietetic, they have technicians. I'll not go through the details of this. We don't have nutrition and dietetic technicians, but the skill development division of our ministry have started some courses in dietetic, which they call diet aid courses or diet assistance courses, but which these courses can be taken after 12th standard. But at the moment, there are no jobs in the community as well as in the government hospitals. So I am the part of the one of the committees, and we have the whole committee members suggested that if we are in skill development, we should also have some posts created in the hospital, and they are very much needed because these diet technicians or diet aides or diet assistants, whatever you call the terminology, they do help. They work under the clinical dietitians, and she get a lot of help. They are trained to take 24-hour recall, the anthropometry, present the history, but they cannot prescribe diets. So they are an assistant to RD dietitians or clinical dietitians. So there are also 9-month courses of clinical nutrition in Western world. There are a lot of doctors who do these courses, and they set up their own clinical nutrition team when they go back to their hospitals. But and clinical dietitians are a part of their team. NIN in our country also offers 3 months and 9 months of advanced nutrition courses. They're focused, but they're mainly focused on community and public health. So they have also started a clinical dietetics wing, but where are the teams? A lot of people have attended these courses, but we still don't have clinical dietetics, clinical nutrition teams in the hospital. So we need to have more knowledge about this. So there are concerns and challenges that there are a lot of promotion of Western protocols which are not applicable in India. So if You do some course, 9 months course. I know a lot of doctors who do this 9 months course from foreign countries, and they said, we are now trained in nutrition. You can't be trained in nutrition because the food pattern in India is different. The diets in India are different. We eat differently. Our physical activities are different. So how, there in Western world, you're taught about the Western protocols, which you can't implement in India. They're now validated for India. So I definitely doctors should be allowed to do nutrition courses, but then there should be some clinical nutrition course within India, because that will make them aware of the food patterns there. So let me add, when we go there abroad to become RD and work abroad, we need to do a bridge course there, because their Western food pattern and Indian food patterns are so different. So how can you become a nutritionist in India by doing some course in Western country and saying that now I can form a nutrition team? No, it just cannot be, because India has different kind of nutrition challenges. So coming to an end, I've taken a lot of time, but I'm very, very passionate about this, talking about this, and especially when Allied Health Profession Council is coming up in a big way. So my hope is a complete transformation, separate cadre of food service dietitians, which is definitely under HR, which is there today itself. Also, clinical dietitians should come under clinical nutrition teams, right? And there has to be super specialty dietitians also, which work in very specific areas like pediatrics, pediatric surgery, endocrinology, neurology. And each neurology, let me tell you, development subjects have different different topics, like different areas. Like autism is a whole lot of new area, and it needs your whole dedication. So separate dietitians are needed who are expert in autism, who are expert in epilepsy, who are expert in SMAs and all that. So genetic disorders, very, very time consuming subject, and a dietitian who's dealing with genetic disorders cannot do anything else in the hospital. So specialty dietitians means getting specialized in one area and taking it forward in teaching, research, and patient care. Improve the rating of our profession. How do we do that? And first of all, to put our Allied Health Profession Council in place. Acknowledgement and approval of the RD board. We have a very robust RD board with Indian Dietetic Association, and it is doing a very good job with introduction of, Ujjwal, and introduction of Adhyay, which they have introduced. And all our, students have really loved it. And we would definitely present it in front of a council when our meetings happen and ask them for adoption of RD board. Uniform curriculum has to be there, course content is to be there, and we need to make nutrition as a professional course, a 4-year graduation with 1-year internship, integrated with medical science. Post-graduation should be there in super specialty areas of nutrition. We need to integrate with medical education. We need to introduce CPDs, and we need to have credit points for nutrition subject-wise benchmark to be set up as different. Promotion based on competencies, not on seniorities. We have to introduce this to have better, dietetic services and better clinical nutrition teams. Then time-bound promotions rather than vacancy-based. And all these are very, administrative things which we need to take up now when the council comes up. And let me tell you, even I have got my promotion after 20 years because it's vacancy bound, and there are very few vacancies created because there are very few dietitians. So where's the motivation and incentive and encouragement, enthusiasm of the dietitians unless more and more posts are created? Recognition of the workload. Let me tell you, dietitians in the hospital work a lot, but it's not rated highly. She looks after food service, she looks after the wards and the OPDs, but she can't do justice with everything. She has 9-to-5 job. So do not let people underrate you. Make your visibility felt. Clinical patient care nutrition is often compromised because she's looking after food service as well. And then she's reduced to only food provider. introduction of CPDs I've already said, promotions, and okay. So most of the time, I'd also add, we are typed as a glamorous profession, and we need to change this perception. There's nothing wrong to be glamorous and well-dressed. Why not? We should be well-dressed, and most of the dietitians are well-dressed. But we need to change this perception that if you're well-dressed, you don't have intelligence. I'm sorry, I do not agree with this at all. Responsible, I would also urge the dietitians to have responsible quotes in the media, and interviews in the social media should be more responsible. So they must take the responsibility of the responsible profession. We should talk about evidence-based practice. We should validate our disease-specific tools for India. We should make the whole thing evidence-based. Consensus-based nutrition protocols and guidelines have to be also put in place. So I would say, recognize your strengths. Let's catch up the pace. We are left behind. Let's catch up the pace. At the end, I would say, when diet is wrong, medicine is of no use. When diet is correct, medicine is of no need. Somebody has very aptly said that. Then exercise is the king, nutrition is the queen. Put them together and you've got a kingdom. So why don't we make our own kingdom? And we establish that we as a dietitians can do Herculean task. We can do wonders. Thank you so much for giving me this opportunity. Once again to all the organizers. Thank you.
Thank you, ma'am. Thank you. As always, I had admired you as the dietitian and the person with a spine who has courage to bring in front and confront the challenges faced, no matter what could be the result. But I really appreciate your upfront talks, and all the dietitians, I'm 100% sure that they all will agree to this, and we all will come together and join you in your movement to make our fraternity more strong, more enlightened, more empowered. Ma'am, thank you very much for this enlightening session. All of us are really feeling the pain which you had discussed over there, and we will work upon it. Thank you, ma'am. Over to you, Vandana.
I equally resonate the thoughts expressed by Mrs. Poonam. Ma'am, what a talk. It has charged us all, and it was such an overarching perspective, and it provided clarity on the whole around dietitian nutritionist debate. It has talked about the thin line between therapeutic nutrition, clinical nutrition, and also at the same time has provided hope and charged us all to work towards a common goal. Thank you so much for this invigorating, enlightening talk. This has set the tone for the session.
Ma'am, we would request you to be with us because many budding dietitians are having not many queries, which we will solve in the panel discussion time. So, ma'am, if you could spare your time, we will be thankful to you, ma'am. Thank you, ma'am. Thank you.
Absolutely. So now moving forward with the scientific session, I would like to invite the next speaker for this scientific session. That is Miss Preeti Soni. Could we have on the screen the introduction?
Shreya? Yeah.
I'm sure all the audience and the participants are equally charged and look forward to more engaging and enlightening talks. So just to brief you about our next speaker a bit, during the time our screen, okay, here it is. The next speaker for this session is Preeti Soni, RD, who's a clinical dietitian, a certified diabetes educator, Sodexo, California, USA. She's a registered dietitian, nutritionist, and certified diabetes care and education specialist. She holds a bachelor's and master's degree from India and dietetic internship from the USA. With 12 years of professional experience in USA as a clinical dietitian, she is an owner and founder of a private practice called NutriCare Wellness, LLC. Her emphasis is on improving gut health, metabolism, and mental health to achieve a sustainable result. The topic that she would be speaking to us about today is critical care nutrition, role of dietitians, and challenges faced by them. So I welcome Preeti to this conference, and thank you so much for joining us all the way from the US of A. And we would love to hear your perspective. And over to you.
Thank you, Vandana, for great introduction that you gave me. And thank you to Ram Manohar Lohia Institute of Medical Sciences, the Dean and the Director, and of course, our beautiful soul, Poonam Didi. And I'm so thankful and privileged to speak among all of you, such talented dietitians and speakers. I'm so glad to share the same platform with everyone here. And I have some of my old friends that I actually did my master's, Avantana, of course, and Smita and Sabha. I'm so happy to see you guys. And I have been working as a clinical dietitian for 12 years in the United States. I have worked in different states. And I would want to especially thank Ms. Anuja, because she actually just defined my whole career, how I actually became a clinical dietitian. And I have worked in acute settings, whether it's inpatient or outpatient. She just described my journey from India, challenges that I had when I came here, and how I became a clinical dietitian. And I would love to share my journey. If anyone budding dietitian who aspire to come here or study or want any help with the guidance, I'm here to help you. The reason that I emphasized or picked this topic today was clinical care, because I work in clinical care setting, ICUs, also along with other floors. But there's a lot of challenges that we as a clinical dietitian face. I mean, of course, there's challenges in every field, especially in this pandemic time. I would say that the challenges have resurfaced more strongly because there was nothing that we knew about COVID, how to feed these patients, when to feed these patients, when not to feed these patients. So it was a learning curve for even us. Like, I've been practicing for so long, but I still felt like I have to learn again. So that resurfaced about like, what are the challenges, how we can improve so that it can help. So if you can put my PowerPoint up, that would be great.
Shreya, can you do that?
Yes, ma'am.
I would like to request the speakers to please try to adhere to the time limit of 10 minutes per speaker, please. I'm sure we would love to keep on hearing to the esteemed speakers, but we would really request if you could keep the talk within the 10 minutes. Thank you so much.
Could you make this a full screen, please?
Actually, this is the PDF form, Preeti. So you had sent us the PDF form. So we are trying to make it, okay?
Okay.
If it's you, this is the PDF version which we are having as a backup.
Oh, okay. Let's work with this only then right now. I don't want to waste time figuring out this, okay? So next slide, please. So the objectives that I picked was, what are the common challenges that we face in ICU as a clinical dietitian is the process-related barriers that can limit ICU nutrition optimization. And then what are and to identify and overcome potential barriers that prevent prescribed nutrition. Despite the recommendation for early enteral nutrition in clinically ill patients, numerous factors contribute to in complete delivery of enteral nutrition. The purpose of this presentation is to identify common barriers that dietitians face to optimizing and delivering nutrition in critically ill patients and suggest solutions to overcome barriers. Next slide, please. If you work in a hospital, you will know that at least 30 to 50% of the patients that get malnourished during their hospitalization. And 1 in 3 patients is malnourished upon admission to the hospitalization. And there's a big reason, because they're not fed at the right time or right dose, or the right formula. So you'll be amazed to know that enteral nutrition in very, very sick people in ICU is held for at least 5 to 7 hours per day. Imagine in 24 hours, you take out 8 hours. So of course, they're not going to meet their needs for calories and protein. And then over course of time, you will see malnutrition happening, which means they will be losing weight. Their situation, their sickness is going to get worse because they won't be able to fight the disease. So some ICU reports at least as low as 33% of prescribed calories. And then process-related barriers. We all know the early nutrition has been found to reduce mortality. Unless clearly contradicted, patients should be fed enterally. Means you need to use the gut, okay? Nutrition support in the form of early enteral nutrition should be initiated within 24 to 48 hours in ICU. And sometime you will be amazed that at least it's been like 3-4 days that the patient in ICU has not been fed. That should not be the practice. Patients that are high nutrition risk or severely malnourished should be advanced towards goal quickly as tolerated over 24 to 48 hours while monitoring for refeeding syndrome. So if you don't feed a patient for 7 days, and then when you feed it, there will be some complications related to. Make efforts to provide at least 80% of your energy and protein goal within 48 to 70. That's not the slide. Let's just keep on the process related barrier slide, please. And then note that there will be complication where you will not be able to feed the patient, okay? So make sure at least you try to feed the trophic feeds, which is just 10 ml to 20 ml per hour in these patients, and then set a progression to meet the best strategy for patients that are actually getting off the vasopressors, So when you work in clinical settings, I hope you will be able to understand some of the terminologies that I'm talking about, but you know about enteral nutrition, which is basically tube feeding I'm talking about. Parenteral nutrition is the IV nutrition. So, but we should always try to emphasize on enteral nutrition first. So some of the process barriers are delay in the early enteral nutrition initiation, inadequate nutrition screening. So not many patients are screened in ICU for nutrition risk. Mostly patients comes in other floors. The doctors will say, okay, this patient looks malnourished, go screen it. But in ICU, how many dietitians screen their patients? I don't think so many. Delay in nutrition order placement, provider under prescribing it, inadequate delivery of prescribed enteral volume despite the adequate calorie prescription. Next slide, please. So the solutions that could be, you need to include a risk assessment, nutrition risk assessment. There are 2 standard ones that you could use in your facility, is the nutrition risk screening and the nutrition risk in clinically ill. That's called NUTRIC. And if you look up online, you'll find the forms and everything, how to implement in your hospital. This will actually help you. This is done by the nursing, I will tell you. This is not done by the dietitian because you're not the first person to interact. So this is done by the nurses. And then if you have some scoring, which is less than, then the consult is triggered to a dietitian, clinical dietitian, when the dietitian will come and then do the whole assessment then. And then initiate enteral nutrition at target infusion rate, quicker advancement, which means increasing rate every 4 hours instead of 8 hours. Okay, so make sure, unless there is a contradiction, unless the patient is very sick or very in like a septic shock where you cannot increase the calories or the rate, but in other in generally patients, commonly we increase by 4 hours. And traditionally, RD will provide recommendation for the type of enteral nutrition formula, starting rate, goal rate, and advancement rate. Ultimately, doctors are responsible for ordering it. This current paradigm can lead to delay because recommendation for enteral nutrition initiation may be given lower priority as compared to other ICU interventions, or not ordered without advancement instructions. So it's really important that nutrition risk assessment is done. Next slide, please. ICU related interruptions. There are a lot of interruptions that happen. Either it's a nursing care, the patient has to take bath, or wound dressings, or bed has to be changed, or infusion bags need to change. And then the nurses usually just go and shut off the enteral nutrition. No. This is now how ICU feeding should be done. Or the enteral nutrition is stopped for a procedure or planning for a surgery or things like that. Traditional practices of placing patient NPO at midnight or 8 hours before a scheduled procedure, or they reduce the enteral nutrition. So actually, a lot of new researchers are coming where actually they continued feeding the patient with the tube feeding while the procedure is going on. But that practice is not very normal yet. It's still under research, but commonly try not to, because what happens sometimes you stop tube feeding at 8 hours and say the surgical bed is not available, the doctor's not available. Now the patient has been NPO for another 12 hours. So has gone a day or two without feeding, and then you say the patient is not improving. So that should not be happening more often. And then ICU transfers happen, or the blood sugar is high, or nursing, the patient may be bloated, or there's distension happening, or dialysis. So there can be numerous problems which can interrupt the enteral feeding. So next slide, please. Potential solutions are that you should try to reduce fasting's time for testing procedures. Some hospitals actually use small bowel feeding, which is basically tube feeding, which goes post pyloric, which means post your stomach and goes in your small intestine, because then it prevents the risk of aspiration, and it can be safely done. But again, this is not a common practice yet. Then you also try to do a volume-based enteral nutrition, which means, say, I'm going to feed a patient 2,000 ml a day, and say there has been interruption for 2 hours. The nursing should be able to adjust the rate, which means they should be able to increase the rate so they finish that 2,000 ml of enteral nutrition that day. So that gives the flexibility to the nursing, and that way the patient still gets the calories and protein that is needed for his healing. But again, maximum hourly rate should be told to the nursing so that it doesn't cause potential intolerance or malabsorption. Next, please. The real and perceived intolerance. This is a common problem. This is a major problem why enteral nutrition is stopped. The bowel sound, that the nursing will check and say, hey, the bowel sound is low, or patient is having GRVs, gastric residual volume. So in some hospital, like even in my hospital that I work, they follow 200 ml. If it's more, they will stop the tube feeding. So we're trying to change that. Unless it's 500 or more, you shouldn't be concerning of stopping the tube feeding, or checking the GRV at like every 4 hours. You shouldn't be doing that. Or the patient has nausea, vomiting, aspiration, distension, discomfort. These are the things which is perceived. It's very hard to know actual enteral nutrition intolerance happening. Next, please. Potential solutions. So what we are trying to incorporate right now in our facility is that we are trying to eliminate gastric residual volume checking, or change to less frequent checking, like instead of every 8 hours, trying to do every 8 hours instead of 4 or 6 hours. And then some hospitals, they use short-term use of like 5 to 7 days of prokinetic agents, which is like erythromycins, like basically antibiotics, but that is not approved by FDA. FDA is a American Food Drug Association, which regulates stuff in the hospital. And do not delay initiation of enteral nutrition just solely based on hypoactive bowel sounds, because that shouldn't be the real reason to stop the enteral nutrition. And alternative changes could be to promote gastric emptying, includes achieving adequate blood sugars control to prevent gastroparesis, promoting regular bowel movements, and minimizing the use of opioids. So a lot of patients who take opioids, their gastric emptying is slow. So if you try to overfeed it, they will be having nausea, vomiting, abdominal distension. So that's where the clinical thinking understanding comes in role. And then try not to rush your patient to get parenteral nutrition, which is IV form of nutrition, because you need to use the gut. If the gut is functioning, the aspirin recommends using the gut first. And if a patient is well nourished and has least amount of complication, is low risk, the patient can go without parenteral nutrition or NPO for 7 to 10 days, unless it's very critically sick. Okay, next slide, please. How many of you have heard, this is how I have always done? The doctors will say, this is how I've always done, I'm not changing it. Or the doctors say, I'm not aware about it, I'm not going to do it. Or the hospital says, you know what, I have not upgraded our policies, I cannot do this. So there is a lot of attitude and behavioral problems that dietitians face. That's why it's really, really important for you to be abreast with latest guidelines, recommendations. I will highly, highly encourage all this new budding dietitian, please just don't stay back to your master's and graduate books recommendations. Go and join associations, go and look seminars, go and join symposiums where the latest guidelines are discussed. Now everything is going global, so it's much more easy now than 12 years ago when I was a dietitian or in India, So lack of awareness, familiarity with current guidelines, lack of self-efficacy, and reduced protocolization is the barrier. Next, please. Okay, so potential solution for this is very, very easy. If you have a ICU doctor, make sure he has a team. He cannot do everything by himself. And especially if you want to promote and advocate for nutrition, you need supporting team members. And that includes a pharmacist, that includes a nurse, that includes a respiratory therapist, because then you get an overall picture and the doctor is there. So you put your recommendation. If there is any contradiction, the nurse will say, hey, I think this may not work. Then you can reassess it. Or the doctors will say, yes, let's do it. And this has been communicated to all the discipline, and the patient will be started on tube feeding on timely manner. You need to have specific ICU nutrition protocols, which is tailored to institution and unit. So it's not just overall, or we're talking about, but it's what your institute ICU has to have some ICU nutrition protocols, like when the nutrition should be, when should the dietitian come and assess the patient, how should she assess the patient, when should the enteral nutrition be started, and when should it be progressed. So you need to have guidelines for that. That way, even if I'm not working today, next person who's working for me knows the protocol and can follow up on it. And then practice audits, routine practice audits are very important. That way you will know that, hey, there's a patient who didn't get fed for 7 days or 5 days. And when it was fed, he had refeeding syndrome, which means his electrolytes was off the balance, his blood sugars were high, organs started failing. That's not what you want to have a patient. Or the nursing advanced rate too fast. So you need to have these practice audits placed in, just pick, and we call it chart review. Basically, we pick a patient, random patient, we look what happened to it, and then if the nutrition was fed timely manner and what was the outcome. So a promising solution to migrating provider-related barrier is the assembly of multidisciplinary nutrition support team composed of dietitian, physician, pharmacists, and nurses. And what it does is basically, it increase the adequacy of calories protein provide, and delay the inappropriate parenteral initiation, and decrease the number of days a patient spends on a ventilator and risk for mortality. Next, please. So this brings me to the conclusion. And remember, dietitian plays a very, very important role in ICU setting. If your hospital doesn't have a dietitian in ICU, then it's a big problem. So make sure, I will highly adequate all the doctors here, all the hospital management team, please have a dietitian or train a dietitian in ICU setting, because they're very important first part of preventing mortality in a patient. Reduced nutrition support can have lasting implications for patients, particularly those at high risk. Dietitian can significantly improve the ICU team capacity to implement and deliver prompt and appropriate nutrition support. Medical nutrition therapy should be considered for all patients staying in ICU, mainly for more than 48 hours. If the patient has been there in 48 hours, the dietitian should have seen nutrition should have been considered. Excuse me. Delivering early nutrition support therapy, primarily using the enteral route, is seen as proactive therapeutic strategy that may reduce disease severity, diminish complication, and decrease length of stay in ICU, and favorably impact patient outcome. So creating multidisciplinary teams to foster nutrition support awareness and continuous education make improve provider perception of nutrition. So the more you educate your doctor about it, the more the doctors will start listening to you. And I so thank my team and my hospital and my ICU doctors. They really rely on heavily. If we tell them this is what you need to start, they don't question unless it's something I'm missing something, then they will let me know. But they rely on us so heavily to feed these patients. I'm so thankful. We are so valued in the team. And I want others to feel the same way. But again, there will be challenges. If you are aware of challenges, I hope this presentation helps you understand the common challenges. Some you may have already been facing it, but didn't know how to address this. Hopefully this presentation is going to help you address those problems and bring it to your team, and then help you in saving one life at a time. So more research is required to identify optimal amount of calories and protein to be prescribed in the first week of clinical illness. So again, there's research coming in, so make sure you are aware of the latest guidelines and recommendations. The more you abreast yourself with the knowledge, the more your team will respect you and help, and you will be a big team member. So dietitians play a very, very important role in ICU setting. And next slide, please. I know my presentation was so clinical based. You may not be practicing in a clinical dietitian, but if you love ICU, if you love tube feeding or teaching about it, I know it can feel very intimidating, or it's just too much to do it. But to be honest, the more you do it, the more you will feel that is a very, very amazing field to work in. And that's my clinical dietitian avatar with all the mask and everything. That's how actually I really look in a hospital. And that's my Instagram kind of post. So if you really want to follow me, I have an Instagram page called NutriCare Wellness RD. You're most welcome to message me. If you like my presentations, send me a message. If you have any question, I'll be happy to help you anytime. So I'm both on Instagram and Facebook, and you can email me also. Thank you so much for this opportunity.
Thank you. I was about to say, but you were very apt on time, so not disturbing you more. Wonderful presentation, and you made many things clear, very clear to our dietitians over here and the health practitioners. Yes, Vandana, I'm really very sorry. I wanted to interrupt for time, but I interrupted for the chairperson session. I'm really very sorry for that. I'm really sorry.
It's always a pleasure hearing you, so it's all right. Thank you, Preeti, for touching the chord, and I'm sure your talk resonated with a lot of challenges faced by a lot of dietitians here, and the point that you brought forth is very pertinent and critical, that ICU dietitians are extremely important. And I absolutely love your takeaway message, that is save one life at a time. And I guess that's what all dietitians and nutritionists aim for. So thank you once again. With that, I would like to invite our next speaker, Dr. Smita Singh. And could we have, thank you. So Dr. Smita Singh is the Joint Secretary, IAPEN UP chapter. She's the Chief Dietitian, Midland Health and Research Center, Lucknow, India. With a rich experience of 16 years in teaching, research, clinical dietetics. She's a Chief Dietitian at Midland Health and Research Center, Aditya Pulmonary Rehabilitation Center, a freelance dietitian, founder and owner of Wellness Diet Clinic, with more than 100 patients, clients monthly who get their diet therapy in weight and therapeutic management. Joint Secretary of the UP chapter of the Indian Association of Enteral and Parenteral Nutrition, Executive Board member of International Society of Medical Nutrition, speaker at many national and international workshops, seminars, conferences, guest speaker at NIPCC, which is a branch of NWCD, UP SACS, Food and Nutrition Board, a nutrition expert on TV shows on Doordarshan, ETV, Uttar Pradesh, News 18, and a nutrition expert of newspaper Dainik Jagran, In Text and Hindustan Times. So now I get it, why do we have your media presence everywhere and get to listen to you, because you're actually educating people around very important health and wellness issues. So it's a honor and a pleasure to have you, Smita. So the stage is all yours.
So much, Vandana. It's nice hearing you from very long time. I feel very familiar in this conference, in this workshop, because there are so many people who are there. When we studied nutrition, we were the batchmates, in fact. So thank you so much for Poonamdi, always. You being a pleasure, and you've been always giving a big platform to work on. So can I share my slides today?
Shreya, can Smita share her slides on her own?
Yes, ma'am.
Yes, ma'am. Thank you so much. Sorry. So the topic which has been given to me was, is maternal nutrition, and basically a ground reality of our country and role of ours, that is dietitians. So simple disclosure, I have nothing to disclose other than my expertise in eating every day. Let's talk about the real challenges which are we going to work on. It is around 810 women approximately die every day with preventable cause, and which is mostly related of pregnancy and childbirth. And when we talk about maternal health, maternal death, almost 95% are coming from low and lower middle income countries, which is one of us. So when we talk about the malnourishment, why we are talking about pregnancy? Because almost 9.7 pregnant women around the world are underweight. And when we talk about in India, it's around 22.9. When we look for the anemia, it's around 40.1% of pregnant ladies are anemic globally. And this figures rises little higher for India, that is 50.4%. So we have to look for this scenario, and we have to change the scenario very well. Apart from that, this is the NFHS 4 data, which says that women, almost 25.3% women are underweight. And when we talk about again anemia, it's around 51.0. The figures are a little bit different because there are various facts and there are various statistics which is telling us this way. This is the data from NFHS 4. And when we talk about SRS 2020, it is mortality rate is around 197, which we have to really work on. So, and when we talk about this antenatal checkup, it is been increased, so 26.4% for our females, for our pregnant females. So we don't have to just say that everything is very, very bad, but this figures tell us that we are a little bit improving in our stats. That is, NFHS 3 has shown that around 37% are only getting the ANC, that is antenatal checkup, for around 37% of 4 of antenatal checkup, and it's been improved to around 51.2, but still we have to work very hard on that. And when we took for the IFA supplements or supplementation in the pregnancy and lactation, we are improving in that too. So there is a drop in anemia cases. When we talk about from the 2005 to 2006, there is a improving maternal mortality rate also. So little bit we are improving, but still we have to work a very, very way. So I just want to share this NFHS 5 data because this data hasn't been, this survey hadn't been completed. We just had the first phase, and just because of the COVID, we don't have the second phase data. But if you see the anemia trends, it's been seen that there's an increase in anemia in pregnant women. This is again a controversial part. We have few states which have a very decreased and in fact improved way, which is they are Nagaland and Meghalaya, but I really want these states to be more in future. And the antenatal checkups, because of all the awareness we have been doing on, we have been increased to the antenatal checkup care visits have been increased to 10.8. IFA consultation was increased by 7%, and there is an inclusive, again, it's been improved for 5.5. So before COVID, if you can see the scenario, is almost 30 million people, pregnant ladies, were recorded, and out of them 97% pregnancies registered with government maternal health system. And this maternal health system gives you a very robust programs, which includes around balanced energy protein supplementation, micronutrient supplementation, deworming, nutrition awareness counseling, maternity cash transfer, and also we screen and care for nutritionally at risk people. Almost 2.4 million health workers were working with the pregnant ladies, and there are 2 flagship programs for nutrition mission, and it's been working with 8 pillars of that system approach one. When we look for this figure, you can see that ANC registration, reception of IFA supplementation, calcium and deworming has been increased, but it was a really drop in the months of March and April 2020, which is just because of the COVID. There are various sectors which we are working in at the time of COVID. Maternal nutrition has never been in sake. We have to take care of it, and we were giving various services, essentials. It was considered as essential services in the COVID response guidelines also. There various video callings, home visits were done to ensure that the pregnant ladies may get what they need to get. So what are the 6 core interventions which has also been guidelines for WHO in 2016? That is balanced energy and protein supplementation, iron and folic acid and calcium supplementation. We have to look for the deworming and also prevent all types of infection and also anemia. And when we see the what we can see all the programs, all the essentials which is to be taken care for the pregnant ladies in India, we are having all greens. So you can see, if you will compare it with all the Asian countries, India is giving all the services to be taken care for pregnant ladies. So, but still we are facing maternal malnutrition. There's various factors which are working, which are promoting this maternal malnutrition, and they are behaviors, food environments, health and nutrition systems, social protection, wash, and education. And today, I'm going to focus only on the nutrition part. So, why maternal nutrition is important and why we are facing the malnourishment? Just because there's an increased nutrient needs, there's a need of there's a woman and physiological and metabolic requirements have been increased. They had to sustain the fetal growth and development to protect the health of the mothers and while pregnant and also while breastfeeding. Apart from the need, you should be taking care of the consideration also. What are the quality and what are the quantity of the food we are working on? What are the pregnant weight gain? Is the pregnant ladies are getting a gain in their weights or not? And about also the micronutrients supplementation like iron, folic acid, and other connections. So we have to take care of each and every part, not only the requirements, but also the way we are eating and what we are eating. So various journals have been shown that this is the why we are focusing on maternal nutrition, because this is the first nutrition to be given to any individual. There are various studies that nutrition of pregnant ladies actually works and it will give you a long-term child health also. So we have to make sure that malnutrition should be there for the maternal health. Because if it's there, then there is a nutrient demand exceeds the supply of fetal and nutrition. And when the fetus is not getting a proper nourishment, there will be an impaired development. There will be insulin decreased secretion, and also about the muscle mass, so that the child in further ages can develop type 2 diabetes or CHD. There are various maternal macronutrient deficiencies also exhibits there will be chances of getting more of diseases in the offspring. So, as everyone knows that there's a continuous transplacental transfer of nutrients from mother to fetus, and we have to adjust all the nutrients for the maternal health. So this is again studies from India, which has been saying that nutritional status is the key ingredient for fetus health. So when we talk about the average intake of the nutrients, you can see that the figures definitely define that all the pregnant ladies, all lactating ladies are not getting nutrients which has been required, which has been recommended by the ICMR. There's been studies from Northern India also, which is exhibiting that only 61.64% of calories are being consumed by the pregnant ladies. 72.46% of proteins are being taken care of, and rather rest have been not taken care. And this slide is telling you about the South India figures. So here comes the role of a dietitian. What we have to work on. We have to look for the energy, because the total calorie cost for the fetus should be around 40,000 kilocalories, and this calories should be coming off from the maternal nutrition, especially on the second and third trimester, as been documented in RDA 2020, which has been additional of 350 calories per day. So you can see that it is the figure which has been when we talk about RDA 2020 and RDA 2010, the figures are the same for the pregnant ladies. That is increased increment of 350 calories in the second and third trimester. But this is the real figure. 18% of the pregnant women are just consuming less than 50% of the calories. So we have to look for where we are lacking, and we need a lot of counseling for these pregnant ladies. If they are getting less than 50% of the calories, they are having the lower serum zinc levels also when compared to the high calorie intake women. When we talk about the protein part, you can see that again it's been increased in the second and third trimester for the pregnant ladies. It's 9.5 grams and also for 22.0 in the third trimester. And this has been seen that again 34% of the pregnant women are consuming less than 50% of the proteins. So again, the figures are really very challenging. We have to see the reality of our perspective, and we have to work again on the proteins part also, which is very, very important for it. Now, this 2020 has firstly given the criteria for carbohydrate content for pregnant ladies and or for all the people. Why? Because we've been seeing many diet plans with very less or no carbohydrates content. So it has been the first time RDA has opt for at least minimum carbohydrates to be taken care of, rather than taking 0 or nil carbohydrate content or very low.
Sorry, Smita, interrupting in between, but we are left with another 2-3 minutes.
Okay,
I'm really sorry.
Fine.
The topic is very interesting, but time is yeah.
Sure, I'll do that.
Thank you.
So
thank you.
Yeah, iron to be taken care of, because again we know that the blood is the only key ingredient, key point where the nutrition is given to the fetus, and we have to look for the iron. Again, 85% of the person is taking less percent of proteins. Calcium, when we talk about the calcium, we have to look for the good amount of calcium, because it's been increased around 100 mg, and around 50% of women are not meeting this number. When we talk about vitamins A, it's again 57% are not taking it. There are various vitamins, vitamin B complexes, which has to be taken care of, and we look for this vitamin B even. Ascorbic acid, it's a key ingredient for all the tissue health and building up of tissue health for the newborn infants, and it has to be increased by 15 mg with the daily requirement. So there are 4 pillars of healthy pregnant ladies: brain health, brain development, growth, immunity, and healthy digestion. Digestive may we have to look for the FOS. Why? Because it stimulates it is very good for the healthy bacteria and for your digestion also. Then we have to look for all the key food groups to be taken care of. And this is the first trimester which we have to look for. The first trimester, we have to look for the folic acid. We have to look for the vitamin A complexes also, vitamin A also, and the ginger is also really going to help you out with the nausea and morning sicknesses. When we talk about the second trimester, we look for the calcium and magnesium. I won't talk about much why it is needed, because I already got an alarm. The third trimester will work for vitamin C, thiamine, and water and fiber. So these are the key nutrients which we have to work by the trimester wise for all the pregnant ladies. And this is a small diet plan which will work for the pregnant and lactating mothers. There are various food inclusions and food avoidance which everyone knows, and we have to look for, and we can share and screenshot this slide also. So special consideration to be taken for the caffeines and also the vegetarian diets, because they are low of iron, vitamin B12, and vitamin D complex, D also. So all we have to vegetarian diets, whenever we plan for the vegetarian diets, we have to take care of them, these nutrients also. So here also there are various, whenever the pregnant lady come to you, there are various, they come up with so many myths. So you have to keep counting on all the myths which has been coming with them. That is nutrition during pregnancy, it is good. No, you have to look for all the truths. We have to look for when to begin the eating healthier during pregnancy, because it has to be taken care before the pregnancy also. Eating fish sometimes says that it is not good for you. You have to clear the doubts that why it is good for you and why you should be taken care of, and also look for this empty kilocalories. Empty calories are being taken much more than the calorie dense foods for them. So small takeaway message for all of you: start your day with a good breakfast, eat regular meals, balanced foods to be taken care of, look for all the types of fats they are taking, look for all the grains, all the fibers, and hydrate a lot. Also follow the salt intake. If you are having any high blood pressure, you look for the salt intake also. And the last slide, I come up with this last slide, which says that Anand Brahma, Raso Vishnu, Bhakti Devo, Maheshwara, Evam Jankatva, Tu Yekatva Kentu, Anna Deshu Na Liptiya. Matlab, Brahma gives you Deva's food, Vishnu the ability to find essence, Shiv cooks this essence into us, and when you eat with this awareness, the food becomes pure and no toxin stays in you. Thank you so much.
Thank you so much, Dr. Smita. It was a beautifully balanced presentation. It definitely brought us face to face with the dark realities and alarming situation which we are faced to around us, and also has provided us with very practical, simple, nutritionally sound solutions. And therefore, I guess we are better off in maternal nutrition now than ever. Thank you once again. With that, I would like to invite our next speaker, and it indeed is an honor and privilege to have Dr. Madhu Sharma amongst us for this session. She's a treasure trove of experience and knowledge, and we look forward to hearing from Dr. Madhu Sharma. Thank you so much for being here with us, ma'am.
Shreya, can you please share the slide of ma'am's CV, please?
Yes, ma'am.
While it's being pulled up, just a little brief about the expanse Dr. Madhu Sharma is. She's a diet consultant, Diet for Life Clinic, former senior dietitian, PGI MER Chandigarh, past convener IDA Chandigarh chapter, NEC member of the IDA. And it is wonderful to have you with us today, ma'am, and the audience is lucky to be able to hear from you. While the CV is being pulled up, I would just like to inform the audience and participants once again that keep your questions ready. We would take them at the end of the sessions during the panel discussion. Please type them in the chat box. Do not start opening up your mics and speaking yourself, and we will take your questions and address to the speakers. So here we are. The topic that ma'am would be speaking on today is the founding years, what is at stake. And she's a former senior dietitian, PGMER Chandigarh, consultant Diet for Life Clinic Panchkula, trained in management of children with cystic fibrosis from Scotland, certified in dietary management in M.B.B.S, Monash University, Australia, with over 3 decades of experience in gastroenterology and pediatrics, Department of PGI Chandigarh. She has several books published on pediatric nutrition, NEC member IDA, and past convener Chandigarh chapter IDA. Once again, welcome, ma'am, and the floor is all yours. We look forward to hearing you.
Ma'am, you will share the slide, or should I?
Yeah, I will share the slides. Shall I share?
So, yes, then Shreya, please you stop sharing. Okay.
So I'm sharing. 1 second. Yeah. I think, can you see now?
Yes, ma'am, we can see your slide and you're audible also, ma'am.
Okay. So very good morning. It's still good morning, I can say, for this, and yes, a very, very happy nutrition month to everybody present here. So at the outset, I would like to thank the organizers and especially Poonam for giving me this opportunity to be connected with your wonderful
My pleasure, ma'am.
platform. And a little bit credit also, in fact, good credit I would like to give to Anuja also for being instrumental in connecting me to you. So it's really good that I'm fortunate that I've been given this chance and to share my on this thing. So is my slide visible? Is it on slide share mode?
Not yet, ma'am. You need to start with the slideshow part. Otherwise, slides are visible, ma'am.
Yeah, but I don't know, that slideshow part is not being.
From beginning, just click from the beginning and it will start now.
Okay, yeah, right. So, and before that, after those heavy thought-provoking and very inspiring and charged talk with by Anuja, it's really I'm coming down a little bit a little lower to the pediatric level, and I'm sure it won't be so heavily charged and though that was very much needed. And then I go on to say that I'm really thankful to Smita, also my previous speaker, who's talked on maternal nutrition, because she's made half my job easy and I can finish on time, because maternal nutrition is a prelude to the pediatric nutrition. So that is what I'm going to talk on the founding years, what is at stake. So why this is so important, because in this nutrition month and the preceding breastfeeding week that we've had, and breastfeeding week almost going on to the whole of month August, that we have been talking on breastfeeding and related topics. It's so very important that the nutrition month that we are kicking off now on the second day, we start with the founding pillar, and that is the foundation of the adult health. So I'll just go further. Now you must have heard of this saying that Indian children are born small. We are like that only. We are small built, so our children also become small. And they are born small, but then actually that is not the fact. Given the optimum conditions and genetic potential, their growth rate is same for any other child, whether they are here or in any part of the country. And this has been collaborated by by WHO and the MGRS growth charts that we follow for 0 to 5 years age group, that actually really emphasizes, and they have shown that from this study, that the optimum nutrition in life, the child born anywhere in the world, if he is having the optimum nutrition in life, he has the potential to develop within the same range of height and weight. And that this potential of development is based actually on more influenced by the feeding practices, the environment where he is born, and the healthcare, rather than the genetics or ethnicity. So, which is very true. And just to give you a picture, just like Smita has talked about the maternal nutrition status in our country, from the data available from the NHS 3 and 4 and also the 5, I'm just going to give you, as she said, that as in the case of the maternal nutrition, even in the pediatric nutrition population, we saw a good increase, improvement in all the parameters like the underweight, whether they're stunting, wasting, or even anemia. Even for children, there was an improvement. These are blue lines bars show the the improvement, the NHFS 4 data, which says which has improved. But unfortunately, and as the NHFS 5 phase survey is still on, it's the first phase that is going on, and due to the pandemic, it was halted. But whatever data we have got from the after the 22 states and UTs, 13 of them still, this is a figure that I'm giving you, that the incidence of stunting is still above 23, almost 30, except for 23, slightly low in Kerala. But then that's not a very good heartening thing. It's not. We really need to work on this. And this is the graphic picture to show you the percentage increase from the 2015-16, the NHFS 4 to the present. This thing that is only in the 4 of a few states which are done. Uttar Pradesh, like Punjab, and really the heartland of the country where, especially in Punjab, which is called the Khata Pita state of the country, and producing a very vast grain producing state. In one of the other studies, it was found that there again, including, overall population of children, is actually the incidence of, malnutrition, including anemia and other things, are very high. So you can see the percentage increase in all of these in this data. And then same for wasting. You can see the percentage increase from the previous NHFS score to the present, status. In most of these states, they have increased. This is how much increase, right? From, starting from anywhere from the lower, like Tripura, Bihar, Manipur, etc., slightly lower, going up like in states like, J&K, Nagaland, Ladakh, and we don't know about UP and Punjab. So, it's a very dismal picture. The scenario has decreased. Now, is it due to the pandemic? Is it the, the slowdown of the midday meal and other programs that was there? We are yet to, that probably has to be checked. And same for underweight, the same thing, the NHFS 5 data has been showing a steady increase in the, incidence of underweight also. So that brings us to ask ourselves, where are we today? It's whether it was pandemic or not, the question remains that we have to do something. And the figures that show are very disheartening. Stunting, which is like, you described it as low weight, low height for the age, has increased in the 13 states. And whereas, the share of the children who had low weight for their height, that also has increased in 12 states, which means there's something wrong in the feeding feeding protocol of our children. So again, coming back to the, why it is important, the founding years, we have been talking of these first 1,000 days since the last month, since the breastfeeding week started. And we know that, I'm not going to go into detail, that because rapid growth happens during these first 2-3 years of life, foundation has to be laid here for nutrition, good nutrition and immunity. The brain development is very rapid, body weight quadruples by then. And the dietary habits in infancy also, that it's now been shown, and very good evidence is there to show us that the shape, dietary habits formed during childhood, and in fact in utero, it shapes the gut microbiota in infancy also, which is a very long-term process, and we come to know the effects of it quite late in life. And how does it impact malnutrition? How does it impact us? It has very devastating impacts on mainly 3 factors. One is, first, it starts from the womb. There's, fetal development is inadequate. IUGR is a result of that. Then once they are born, low, their fetus, development is low, they are born low birth weight is there. So then during these first few years of life, because of that setback, which is probably not filled up during those first 6 months of exclusive breastfeeding, and then later on also, there's cognitive development, which is impaired, and other factors also. And then this does not stop there. It carries on to your adult life also, with increased risk of metabolic syndrome early in life, Barker's hypothesis, and which I will not go into detail. So what actually happens if malnutrition occurs at this stage itself? It is an irreversible damage. We don't have any window over here for the children, like in adolescence or in pre-pregnancy, etc., to make up for that. And so what we do have left in hand is only prevention. So our role as dietitians and nutritionists, is only to prevent, create awareness. So that's what I'm going to, stress upon. Now here you see a child. He looks very nice and, chubby child, and looks quite healthy. But do you think he's really healthy? How can you say? Just by the looks of the child, can you say, is he healthy? Because in the state of Punjab also, we have seen that, in the middle income socioeconomic status, and in the good background families also, there's acute, deficient, they may not be deficient in their proteins or in the calories, they might be over nourished, but there's something lacking in them. You cannot call them healthy. So how do we describe a healthy child? We have these parameters which we say that, you have to see whether the growth is adequate. If the child is growing well, you can assess the growth right from the child is born till when he's 6 months and, later on. And then if he's growing well, does that, is he healthy enough to resist any infections during the course of his life? whatever type of environment that he gets, that means he should have good immunity. And then if he has these two, then he should be a bright child in the sense that his mental performance should be good. So basically what the nutritional status is taken as a global indicator for the well-being of a child. So that is why it is very important. Only then we can say whether this child is healthy or not. And which brings us to the status of India. Almost 98% of these apparently healthy school children had inadequate intake and lower levels of many of the essential micronutrients. So it was not necessarily the macronutrients, but the main problem was with the micronutrients, and they were not getting adequate amounts as per the recommended allowances, or probably the EAR also as the latest guidelines. So this brings us, where is the problem? The macronutrient deficiency, which is now known as, it is very well recognized as the hidden hunger. It's a global problem and more ignored and underappreciated. So it's basically not malnutrition here, we'll call this as poor nutrition. So which results, which is a result why it is happening, because it's not balanced. They are just getting calories probably, and some proteins also they may be getting if they're having good amount of milk, and maybe non-vegetarian child in a family, in the community, they might be getting some from their animal sources. But then the micronutrients are not there, because a lot of other essential the food groups that are left out are not filled up. So the extent of this is incidence is almost 2 billion people around the world. Globally, this is a problem which needs great attention. So what is at stake? What we come to the basics now. Why this happens is basically we have to see the behavior. The eating behavior itself is at fault, not for the, and if it is at fault for the children, it's definitely at fault, start in the family, in the adults. That is why it is being passed on, it is being inculcated by the child, and it's given to the child. So that is failure to thrive, because they think they're eating well. They are actually, but then they may not be growing properly. They may be growing well, but they are having poor nutrition. So anemia is one of them, very, very, very stark. And then there's another spectrum of this malnutrition, which is obesity, which is again a very, getting epidemic proportions, assuming epidemic proportions in our country in children. So coming to the eating behavior, again, as in the maternal nutrition, Smita had highlighted, what are the requirements? Counseling and awareness is important for a healthy balanced diet for mother, all that she described. And then exclusive breastfeeding for the first 6 months, which is again very much lacking, even in the educated classes here, because of so many, avoidable factors. They may not be getting the privacy, they may not be getting, there are so many, people around giving her false signals that her milk is not adequate, or, she's too weak and all, or some, the practical problems of the joint families, etc., where some joint families, they do take care of the mother, of the child when the mother is at work, or she's around, not being able to be around for some time, few hours or so. But then that can also have their own problems when she is expected to do all the household work, look after the children, and not get the support. So not many things. Complementary feedings are maybe delayed. There may be exclusive breastfeeding for almost a year, not 6 months. And then feeding bottle is the big culprit. At least in my experience, I've seen that. And I was very, very particular when my wards in the pediatric center, that I did not allow a single bottle in the ward. And I used to go and sit with the mother, ask her what the problem. She says, "To leta hi nahi hai, peeta hi nahi hai." So I used to sit with the mother, take away the bottle, and hide the bottle in the nursing station, and sit with the ask the mother to use the bottle, the spoon and the cup, and feed. And the child was actually accepting. It's just that, the child has to get adapted to it, and the mother has to, get used to this idea. So it's our role to how to implement, how to teach them. So again, discouraging tea and junk foods to children, that is prevalent everywhere, and especially in North India. I don't know about the rest, but in North India, tea is given for any little thing, cold, cough, ho gaya, gala kharab hai, anything that happens, tea. And if the child doesn't like milk, they will put tea in, leaves in that, and feed it through the bottle also. So all this needs, education regarding all home-based diets and proper things. So that has to be done. So one more thing I want to highlight here is, though it's a little old study, which was a very nice study done, feeding infant and toddler study, FIT study, which actually they highlighted that, what kind of foods were being offered to children and what the result was. They were offered the 0 to 5 year age group. They were offered very low nutrient density. It might be, rich in calories and other things. High fat and sugar, sweetened beverages and cereals, cookies, processed meats, and all those kind of things, which actually they were getting the energy, almost the energy that their total requirement, 90% of this, the energy was coming from these foods. So you can imagine if these foods would be, how much other nutrients they would be providing. And then right from their birth, the first year of life till the end of the almost 2 years, the consumption of the mainly carbonated sodas, chips, cookies, biscuits, etc., actually gradually increased. And so these kind of dietary trends that places the toddlers and them infants at increased risk for inadequate essential vitamins, especially iron and calcium, which is so important. So what their guidelines was the same as has been stressed upon earlier, that you have to bring diversity in food by including all the food groups. And actually the mother has to be encouraged for food diversity right from the time she not only conceives, in fact from the adolescent age, we should go back to that stage actually. And that way her own nutrition also will be taken care of. And during the pregnancy and the lactation phase, the amniotic fluid and the human milk, the nutrients will be transferred. And that will promote healthy breastfeeding also. And mothers have to, the developmental milestones, it's very important they should recognize, at what age. It has to be very, age appropriate, complementary feeding has to be done, and in very gradual manner, and in a, age, texture, all those those factors have to be considered. So they have to be given, made aware, educated on how to recognize those cues. And one important fact that came out from the study was that.
Sorry to interrupt. Ma'am, we are running short of time. 3 minutes.
Okay, fine. Okay. So this is what, they needed multiple exposures to get used to the, new diet. So that's very important. And then the weaning bridge. I'll just give in short this. This is the basic malnutrition pit that occurs between one phase of the breastfeeding phase till the solid family pot feeding, and this pit of malnutrition can be tided over by the safety net of the 4 pillars that we have: the continued breastfeeding, the vegetable animal protein, supplementary foods, and group eating. So this once the child tides over from this phase to this phase, then there should not be any problem. So basically, all those factors of ignorance, all these heavy cold foods concepts should be removed, eradicated. See, all these other factors that actually go to impact the practices, they are not prepared. So all these practical things we all know, these have to be taken into consideration and have to be tackled at the grassroots level. And the consequences of these cognitive failure to thrive, morbidity and mortality is a short term consequence, and long term also I've described. And this is a vicious cycle of malnutrition and infection, undernutrition, leading one to the other. And again, I'll just suffice it to say that almost half of the childhood deaths in developing countries could be averted by eliminating malnutrition through healthy practices. And this is again for anemia, the same prevalence has increased from the previous NHFS 4 to 5 this thing in the most of the states, which is not yet complete. And again, in the previous data survey, it was found that this percentage of anemia was across the gender, across the education level, or the urban or rural conditions. So this has to be worked universally. And interventions, what is required is giving, education. And one more important thing is the Anganwadi's condition, because they are the ones who are going to enhance do the groundwork. They need to be better taken care of in terms of better wages and better living conditions, etc. And the implications of obesity, just last 2 slides, that, if again they go to the other extreme of obesity, and in the child in the developing formative years, this can increase to long-term implications of adult onset diseases. And type 2 diabetes, hyperlipidemia, hypertension, PCOS in girls. These are being commonly seen in most of the children in the pediatric OPDs also. So intervention, again, the same thing that I mentioned earlier. These I need not repeat, and almost a repetitive thing, that the intervention has to be really very sound. So in the end, I will just say, by quoting a very nice quote, many of the things we need can wait, but the child cannot. The right time, and right now is the time. His bones are being formed, his blood is being made, and his senses are being developed. So to him, we cannot answer tomorrow. His name is today. So thank you for the time, and I really loved interacting with you all. And any questions, I'm there to take. Thank you very much.
Thank you so much, ma'am. It was a very comprehensive talk, and we really appreciate your valuable insights. I'm sure the audience has gained quite a lot from this session. Thank you so much for your practical solutions and also the glaring statistics. It was great to have you. Thank you so much. And questions we'll take at the end during the panel discussion.
Sure.
I'm sure there'll be a plenty. With that, we come to our next speaker for this session. That is Sabah Umar. And I must mention here that
I would request Madhu ma'am to stop sharing.
Yeah,
her
I'm
screen.
not able to. Can you? I don't know, that has disappeared. I've come to my desktop. So
actually, if you just
stop video
cursor and go on view options, you can say stop sharing, or just click on the green button.
Wait.
No, it says stop. No, it doesn't ask me. I can't pause share here. Pause share or stop?
Stop sharing, please.
Okay, stop share. Yes.
Thank you so much. So I must mention here that Sabah is quite well into midnight, and yet she is here to address us all. So thank you so much for sacrificing your beauty sleep and talk about hepatic nutrition instead. Could I request the slide for Sabah to be put up, please?
Shreya, can you please do? Yeah.
Thank you so much. So we have Sabah Umar, a nutritionist with Polygon HQ, Richmond, Texas, USA, who is here to address us around hepatic diet, how to address micronutrient deficiencies. A very pertinent topic indeed, and interesting. She's a nutritionist with Polygon HQ, a nutrition manager with Limitless, a nutritionist and wellness coach with AmeriFit personalized weight and wellness management, a nutrition writer with Demand Media Inc. So welcome, Sabah. It's indeed a pleasure to have you here. And as always, we love hearing you. You have so much information to disseminate with so much energy. So the stage is all yours. Enthrall us. Thank you.
I would like to share my screen, if that's okay.
Yeah, absolutely. Please accord her the sharing rights.
Yes, ma'am, she can see it.
Thank
you. Can you guys see my screen?
Yes.
Okay, now before I begin, I would like to thank Dr. Ram Manohar Lohia Institute of Medical Sciences, the Department of Dietetics for doing this. It is a great honor, and it is I feel very privileged to be amongst such a great list of speakers and people. The Dean, Dr. Nuzhat Husain, Dr. Pradeep Saxena, Ms. Anuja Agarwala, Ms. Vandana Sheth, Dr. Madhu Agarwal, who spoke before me. And it is such an honor, and it is such a pleasure to be with my old batchmates, Vandana, Smita, and Preeti Soni. You guys, it's always great to see you. And most of all, I would like to say, Ms. Poonam Tiwari, Mrs. Poonam Tiwari, you've been my senior. I've always looked up to you. And it's amazing that even after 15 years, I'm still looking up to you because of the amount of work and sincerity of work that you do. And I mean, it's very impressive, and thank you for being you, and thank you for giving me this opportunity. I would also like to start by talking about what Ms. Anuja Agarwala spoke about, differences between nutritionists and dietitians. And Preeti Soni is actually a dietitian here in the US, while I'm a nutritionist because I did not go through the internship program that Preeti did. But however, I happen to be in Texas, where not everyone can call themselves a nutritionist. You have to have a minimum of a four-year degree in nutrition. And I'm also a certified health coach, for which you also have to have a 4-year degree in any health sciences. And as Dr. Pradeep Saxena was talking about, after I moved to the US 15 years ago, I focused more on prevention and management of lifestyle diseases and less on clinical, because I'm not technically qualified to do that. Speaking of which, why am I then talking about hepatic diet today? Well, it's because before I moved here, I was working in PGI under Dr. Chaudhary in the gastroenterology department. So I feel like I've worked in this field, so I'm fairly confident that I'll be okay doing this. So let's talk about the hepatic diet and addressing micronutrient deficiencies. So the thing with liver diseases is that patients are at an increased risk of micronutrient diseases. And I'm not talking about protein calorie malnutrition, which is very common with liver problems. We're talking about micronutrient deficiencies here. Now, why is that also very important amongst patients with liver disease is because of the impaired vitamin synthesis, activation, storage, and adequate oral intake as a result of poor appetite, gastro problems, early satiety because of ascites, and chronic disease. So it is a challenge to also manage nutrition in liver patients because of these alterations to metabolic and storage functions of the liver, and also because the use of traditional assessment tools such as anthropometric and biometric measures is difficult because of complications, again, because of the complications. And malnutrition is prevalent amongst liver patients and is an important prognostic factor. So my next slide is about the progression of liver disease. As you can see, as the liver disease progresses, the metabolic alterations become more and more pronounced. Clinical decomposition in advanced liver disease, regardless of the etiology, often results in noticeable complications, including ascites, which is basically inflammation and sodium retention, esophageal varices and variceal bleeding, hepatic encephalopathy, spontaneous bacterial peritonitis, and hepatorenal syndrome. Now, the only definitive treatment for advanced, that is the last level of liver disease, advanced liver disease, is liver transplantation. For patients living with advanced liver disease, treatments and therapies should focus on preventing and managing complications. However, we're going to talk about earlier stages where the person is not in the last stages, and how do we manage that? So we talk about what's really common, especially here in the United States, is alcoholic liver disease. Now, chronic alcohol. Okay, just want to say one thing. It's 2 a.m. here, and I'm kind of not 100% right now. Chai can only help you so much. And so please forgive me if I'm eating up a few words in between. But anyway, so we're talking about alcoholic liver disease, and chronic alcohol use can lead to liver damage with a broad spectrum of hepatic manifestations, including alcoholic steatosis, alcoholic hepatitis, alcoholic steatohepatitis, and alcoholic cirrhosis. Because of the liver in the primary site of ethanol metabolism, hepatic steatosis may be seen within 2 weeks of regular alcohol use and is present in approximately 90% of heavy drinkers. So the following micronutrient deficiencies are commonly seen in alcoholic liver diseases, which is thiamine, riboflavin, niacin, folic acid, vitamin B12, vitamin A, C, D, E, magnesium, selenium, copper, zinc. Compare this to non-alcoholic fatty liver disease, which is known as NAFLD, which refers to the presence of hepatic fat also, which is around 5% of the liver's weight is fat, but with no history of significant alcohol. And as you can see in the next slide, that the micronutrient deficiency is actually significantly lesser in non-alcoholic fatty liver disease as compared to alcoholic fatty liver disease. The reason I bring this up is just reminded me of Amitabh Bachchan dialogue from a long time ago when he said, "Daru peene se liver kharab ho jata hai." People thought that was comedy, but to me that was actually profound nutrition advice right there. Daru peene se literally liver kharab ho jata hai, as you can see over here. Now, if I go back a little bit, actually, yes, I want to go back to this slide just to talk a little bit more about it. Quickly talk a little bit more about liver diseases. There's also NASH, although that does not make much of a difference on the diet compared to alcoholic liver disease. Then hepatitis, which is characterized by inflammation of the liver. Although inflammation may develop, well, there are basically 5 types of hepatitis viruses, the most common being hepatitis C, as most of you might know. And approximately 50 to 85% of patients with hepatitis C develop chronic hepatitis, and 5 to 30% of those patients further develop cirrhosis. And cirrhosis is when, as you can see, we're in the worst stages of micronutrient deficiencies. Certain medications used to treat cirrhosis, like ribavirin and interferon, itself cause deficiency in calcium absorption, interfering with vitamin D3 production. But then again, it's a tough situation. That do you give medication to solve the disease, or do you just focus on micronutrients? So it's a two-pronged approach that we need to look at. Another problem while dealing with liver diseases is nutritional assessment. Now, the diagnosis of malnutrition can be challenging in the earlier stages of cirrhosis because there is no consensus about the best method for quantification and classification of malnutrition, and the cost effectiveness of evaluating all patients is not established. Well, that's because of the sodium retention and because of the ascites. The biochemical, the anthropometric parameters, including weight and body mass index, are altered because of this electrolyte disturbances and renal failure and presence of edema, and therefore low sensitivity and reliability in these patients can be found. And this is why we cannot 100% rely on measuring skin fold thickness and other hydropic changes, and therefore the European Society for Clinical Nutrition and Metabolism, ESPEN, or ESPEN as we call it, they suggest is that we need to use what we call the use of multi-parameter data. That is, in the initial stages, the society recommends that we use indirect methods such as dietary recall, which I'm pretty sure all the students here are pretty good at. I remember we were taught that really well in India. The subjective global assessment scale, which includes elements of clinical history, physical examination, and it is validated for the assessment of nutritional status in cirrhotic patients, and we provide prognostic information. So after we've done that, after using indirect methods such as the SGA scale, because they're affordable and adequate, the next stage we can do is, after the identification of that, we can use quantitative methods, and the most easiest and reliable amongst them is bioimpedance, or BIA as they call it. But still, even after that, it is extremely difficult to assess the nutrition levels of a cirrhotic patient, especially in the early stages. Now, if you look at data, we find that the most the micronutrients that are most affected by liver diseases are vitamin A, which is prevalent among 93.5% of patients, vitamin D, 94.5%, and zinc, which is 85.6%. Now, why this happens and how this happens, for me, I could move this. I see myself over here. I would rather see this over here. I'm trying to wrap this up early because I know there are so many questions that you would want to ask the rest of the speakers. Yes. So with vitamin A deficiency, the risk factors are because of the malabsorption, the decreased hepatic storage capacity, and also zinc deficiency, which is interdependent. And what this suggests is 2,000 to 200,000 IU daily, orally. While vitamin D deficiency occurs because of impaired hydroxylation and reduced synthesis, and again, gastrointestinal malabsorption, and again, 50,000 IU of vitamin D2 or 6,000 IU of vitamin D3. Basically, oral pills are what is recommended for these two major deficiencies. For the rest of them too, multivitamins is what is generally recommended, especially in the early stages. And then zinc, which is another major one, major deficiency that's found because of decreased serum albumin synthesis and because of altered protein and amino acid metabolism, because of which zinc is not being able to produce as well. So again, that is again 50 mg of elemental zinc is recommended. What that means in terms of actually eating the food is, when we talk about fruits and vegetables, we choose fresh produce when possible, as canned varieties are higher in sodium, and acids or sodium retention, because of which inflammation occurs, is pretty common in liver diseases. So try not to get any canned foods or canned fruits, just focus on fresh. As far as dairy is concerned, because of fatty liver, it's not advised that you have fatty, like full fat stuff, but do have low fat Greek yogurt, small portions of low sodium hard cheese, and fortified dairy-free milk alternatives like almond or soy. In terms of grains, preferred as always, and I've seen this is pretty well done back home in India, although this needs a lot of focus here in the United States, to choose whole grain bread and whole pasta, brown rice, cereal instead of refined. Everything over here is so refined that sometimes suggesting whole grain, cereals is like, okay, I mean, what are you even talking about? Another problem we face here in the United States is the red meat issue, the protein issue, which isn't approved for cirrhotic diet at all, because especially, and also the processed lunch meat or sausages, small servings of lean protein, lean poultry without the skin, and some types of fresh fish, such as salmon and eggs and egg whites, may be suitable. But try to get most of your protein from vegetables. Again, if you're looking at fat, desserts are not really recommended. Beverages, and of course, and this is obvious, especially if you remember Amitabh Bachchan quote that I did 2 minutes ago, दारू पीने से liver खराब हो जाता है. So try to avoid alcohol as much as you can. And if you have water is the most hydrating choice, but if you are on a low sodium diet, you want to check the labels on bottled water as well, because some of the bottled water have sodium as well. Milk and juice should only be consumed if pasteurized. Now, there are also some certain extra modifications needed in the diet, especially in terms of how much to eat and when, because patients are generally not in a state to eat a whole huge meal, and it has to be broken down into many small meals given their condition. And also, if you have ascites or the accumulation of large amounts of fluids in the abdomen, doctors usually restrict usually require a strict no salt diet with up to 88 millimoles per liter every day, while the typical American diet has 200 to 300 millimoles of sodium per day. Similarly, if you have encephalopathy, as the body digests protein, it becomes a byproduct of ammonia, and there's extra ammonia which starts affecting your brain, and you get dementia-like symptoms. That is called encephalopathy. If you have that, then focus on a plant-based diet only and avoid meat at all costs. So in conclusion, I would like to say that nutritional deficiencies, especially micronutrient deficiencies in chronic liver diseases are very prevalent and are associated with compromised outcomes in the population. The cause of malnutrition, as we discussed, is multifactorial, which includes anorexia, insufficient digestion, absorption, impaired metabolism. The diagnosis of malnutrition can be challenging, as we discussed, because of all the especially in the early stages of cirrhosis, and although there is no consensus, again, the dietary recall method and the use of SGA and or anthropometry and the bioimpedance is still considered the best method, but a lot of research is needed to identify all these deficiencies earlier rather than later, because when it's later, I mean, we go into fixing mode, we go into what we say defensive mode instead of being in a preventative mode. But here's the good news: even if it's alcohol-related liver disease, if you are able to avoid alcohol completely for 6 to 8 weeks, we are able to reverse most of the problems that it's causing. And for people who are not in an advanced liver stage disease, who are not having advanced liver cirrhosis, the good news is you can, as long as you're avoiding processed foods, as long as you're avoiding extra sodium and you're eating fresh and healthy, you can. And this is what we focus on, we give the patient empowerment, tell the people that we're talking, tell your patients general, not just about liver, in general, you have to make your patient feel, we don't even call them patients here sometimes, you have to make your client, you have to make your customer feel that they can do it. Give them empowerment, make them feel empowered that they can do it. I mean, if you look at it, basically avoid alcohol, avoid junk food. It's not that tough, and just convince your patient that this is something you want. This is coming from you, not as a command from your nutritionist or your dietitian, but as something that they want. So with that being done, malnutrition is a potentially reversible condition that, when identified and treated appropriately, can lead to improvement.
Sorry to interrupt. 2 minutes left. Okay.
Oh, I'm done. Actually, I'm done. That was it.
Thank you. You were apt on time. I was sorry for that. I'm sorry for that.
No problem. How do I stop share? Okay, thank you. Hello.
Thank you so much, Sabha. It was a wonderful session and very informative. So I now pass on the floor to Poonam Di.
Yeah, I would request all my speakers of this session to be there, because some participants have raised their questions. The first question, Sabha, 2 questions have been raised, rather 3 had been raised for your talk. The first one is food supplements for fatty liver. What do you have to say for what kind of food supplements you will recommend for a fatty liver person?
So food supplements, as in, see, first of all, I mean, by supplements, you mean anything. I mean, because supplements here means something else. What I'm trying to understand is what supplements mean. Because if you're talking about multivitamins, that's highly recommended if someone has fatty liver or early liver disease, because it, given the statistics, it eventually does lead to malnutrition. So yes, multivitamins is, but as far as any other protein powder or any other kind of thing is not recommended, because we're trying to restrict sodium. So any processed food would not be preferable. Try to stick to fresh fruits and vegetables as much as possible.
I hope you must have got the answer, Priyaji. The second question is from Sonal Kesarwani. She wants to know that if someone is having a fatty liver, he or she should be given insulin or not?
Well, so that's a, I mean, I don't want to overstep my boundaries. That's a doctor question, but from what I understand, I mean, sugar has to be treated, diabetes has to be treated, and it's a multi-pronged approach that has to be done by the doctor. And I don't want to say if you, I mean, in insulin, how much and when to be given is something that is not in my scope of.
Yeah, I agree.
Yeah.
I agree to Sabha. The reason being, okay, your liver is fatty liver. It's a second stage. It's not able to, but the primary treatment, if your diabetes need to be treated out with the help of, with the help of insulin, then go ahead with the advice of practitioners and your endocrinologist. But yes, we are not the one to say for it. The second one, the question is like, if somebody is on, say, Priya Singalji has asked again, if somebody is on second stage fatty liver, what should be, what supplements and food should be considered? It is the case of NAFL.
So with the case of non-alcoholic fatty liver, NAFL, the thing is, let me just look into my notes, but the main thing with non-alcoholic fatty liver is that it does not affect malnutrition and micronutrients as much as alcoholic fatty liver does. And so because of that, it's fairly harmless, and only about 15% of those patients develop what they call NASH. NASH is the non-alcoholic steatohepatitis, which is an inflammatory disease. Now, what happens in NASH is that it is indistinguishable from alcoholic steatohepatitis, and it increases the risk of developing cirrhosis and hepatocellular carcinoma. So if a non-alcoholic fatty liver person has advanced to the stage of NASH, then of course we should start with multivitamins and whatnot. But if it has not reached that stage, then just a regular healthy diet is what we would recommend.
One more question has come up for Sabha. Sabha, I think people have been very much inquisitive about your talk. If GGT levels are raised, then what nutrients we can add to reduce the levels?
If GGT levels are raised, then what nutrients
we can add to reduce the levels? And second, also, like, what are SGOT and SGPT, ma'am? Please let us know. Tuba and Tanveen has asked these questions.
So so the thing is, GGT and SGOT and SGPT, what do they stand for? I'm not even sure, because
yeah, I'll tell Sabha. If you remember the serum, these are the liver enzymes and GGT levels.
Okay,
when they want to ask about that.
Okay. I mean, once again, if the enzymes and all of them are increased, then it all comes down to what that level of increase is and where it stands in the whole spectrum of liver diseases, where there's a whole progression, where it stands on that. So if it's high and nutrients, what nutrients can be added to reduce the levels? So as far as reducing the levels, nutrients cannot reduce any levels at this point, because what we're trying to do over here is prevent malnutrition, prevent any deficiencies, prevent protein calorie.
Despite of eating healthy, some kids develop dental caries. What can be done to fix it?
Okay, very, very relevant question. And like I could not talk much on the many issues because of the lack of time. The dental caries in children is basically because, again, of faulty eating, feeding behavior. And basically it is the fault of the feeding bottle that is introduced in the early life, and that carries on. The bottle is there in the oral cavity of the child, for very long, and then you cannot brush the teeth of the child, so often and frequently, and bacterial contamination and growth happens very, very fast in that, it becomes a very perfect media to for the bacterial growth to happen in the oral cavity, and that is how their first teeth, you see, it's not in children, it is called bottle caries, not dental caries. Like actually we call it bottle caries, and the feeding bottle is the one to be blamed. And so because till 6 months exclusive breastfeeding is done, there's no issue. But once, when their complementary feeding starts, and they are given solid, food, cereal-based, pulse-based, vegetable-based foods in various forms, age-appropriate timings, so that this problem will not come. And then, by the time the child is 1 year, if he has not got exposure of the plastic, nipple of the bottle in his mouth for that long, then this doesn't happen in all children. It happens only in most of the bottle-fed children. That is where, and then again, sweetened beverages are given through the bottle. In North, I've seen in our hospital, I used to see tea is being given, sweetened tea given through the bottle. So they are constantly exposed to sweet and milk. It's very good media for bacterial growth. So that is the main thing. So it's basically.
Thank you, ma'am. Yeah, thank you, ma'am. It was, I think, Tanveer, you got the answer for your question. Anuja, ma'am, there is one question which talks about, Priyaji has asked that where can one do NTP course? She wanted to know about from where to do the NTP course.
Okay, see, this course has been recently, this is the technician's course. This has been offered by skill development of the government. Not really very widely advertised. Some of the universities, I think in Ludhiana, they are offering, because these courses are offered by the hospitals can be the takers. I think there are very few takers for this. But their diabetic educator course, which is also after 12th standard, because of the public health problem again. So they're offering a very intense course in diabetic educator, in which I was one of the committee members. It is so intense that even our MSCs are not done that kind of a course, elaborate course. So we suggested that why don't you allow M.B.B.S and MSc students of ours in nutrition to do this course? This is so extensive. It has an internship program also along with that, right? Rather than people coming from just any stream or some graduates doing it, because finally what they will do is they'll open their own clinics then, right? Here, you are expecting a clinical dietitian to do a graduation, then do an internship, then register in the registration council, which is going to come up, then do a post-graduation for super specialty. And there you are, inviting 12th standard and graduates to do the 6 months course and become diabetic educators without even registering them. So I think doing a diabetic educator course will be very, very helpful. It is very good. Okay. So, and I had recently advertised it. As regards technician course, we will have to see who are the ministry has just laid down the course outline and the manual. Now, hospitals can take up as their course through the ministry. So there are very few takers. I know Ludhiana has taken it up. I can, Swati, what's her name, that dietitian's name? I can share with you the details.
Right, ma'am. I'll provide the details regarding the course to these people. Then there had been one query, CRP levels on blood. Tuba Khan wants to know, please let us know the CRP levels on blood. It's very simple. Any of the speakers might clear it out to her. She just, I think, ma'am, please enlighten us on CRP levels on blood.
Well, what I can understand is, CRP level. CRP basically an indicator for heart risk disease. But now, of the past 1.5 years in the pandemic, it has been taken as an indicator for infection and this thing. So yes. CRP level should not be higher than 5, 4, or 5. It should be below 4 or 5. So that basically indicates inflammation of the body, any kind of an inflammatory condition in the body. So then it's more of like a clinical thing, but yeah, because of hearing it so often during the past 1.5 years or 2 years, this question might have come. And CRP, as far as the diet part is concerned, nutritional part is concerned, I think if you look for an anti-inflammatory diet, basically that can help in a good protein diet. So right. That's my understanding is, I think if anyone can clarify more on that, I'm not sure.
No, ma'am, thank you very much. The things had been there for them, like these were the questions. Very enlightening one. As the takeaway message of these scientific session, we can say that Dr. Anuja ma'am had very aptly said that now it's high time for all of us to be sensitized towards our own profession. Why we have come to this profession, what is our mission and vision in life, what actually we want. Is it only the salary part, or is it the everything included with your job? You want to earn that. So please raise up. Please don't be now so casual with your careers. Come up together, go for these awareness programs. And in future, I know very well, I'll share ma'am's email ID and the Facebook ID even, where you can ask her. She's planning many more huge projects in the pipeline, which will help us as dietitians, our community a lot. Then we had very good speaker on, when we had we were discussing that Smita has very nicely expressed upon the ground realities which we are facing for pregnant ladies. We have to work on that. We really need to take care, because that is going to help us out, not only for preventing malnutrition among the pregnant ladies, but also our future generation, that is the founding years kid. Preeti, you had taken the topic which was unexplored, and we really hesitate in learning more about it, the critical care medical nutrition. And I'm really happy that you covered it very nicely. Dr. Madhu, what to say, ma'am? Your lecture was something which we all need to learn upon, because that makes the founding years foundation very strong. And we really, the way you have said in the last line that today, they are not the tomorrow, their answer cannot be for tomorrow. It is today that we have to address their problem. So I agree to it. Yes, ma'am.
May I just interrupt? I wanted to say it earlier. Just a little correction. Please don't address me as a doctor.
I'm so sorry. Madhu,
so that okay. I just wanted to say.
Okay,
so
thank you.
Just Madhu Sharma is enough. Okay, thank you.
Thank you, ma'am.
Okay.
Then I had Sabha, who on my request, with her past experience with Dr. G. Chaudhary, she has tried to do justice with the topic. And Sabha, thank you very much for making you awake in these odd hours. I can see the clock is saying 2:15 for you. So I'm really sorry for that, but thank you for your patience. And with this, we come to an end for our scientific session 1. We will quickly move for our scientific session 2. I could have given a break of 5 to 10 minutes, but then I came to know from my IT department that they had another meeting scheduled right at 2:30 p.m. So now this will be a jam-packed session. Please forgive me, all the speakers, for the coming session. I'll be more time-bound, and I would request everyone to be more time-bound. Thank you very much. Thank you all these speakers for being here and solving the queries. It was really an intellectual treat for all of us. Thank you.
Thank you so much.
I would request Shreya to start with our scientific session 2. Shreya, can you share the slide fast? Yes, please do that fast. This is our scientific session 2. I have my session chairperson, Ma'am Anuja Agarwala, madam. Ma'am, thank you very much for accepting this. Then I have our keynote speaker, Dr. Renuka Jayatissa. She is from Sri Lanka. Archana Sinha, Prachi Chandra, Dr. Avantina, and Mary Murphy from United States. So let's begin the session without taking much of the time.
Should I introduce our keynote speaker, Dr. Renuka Jayatissa, right? Am I pronouncing it right? She's the head of the Department of Nutrition, Medical Research Institute, Ministry of Health, Colombo. And she's also a visiting consultant, medical nutritionist at the National Hospital of Sri Lanka. She's also chairperson of Interim Specialty Board of Nutrition, Postgraduate Institute of Medicine, University of Colombo. Also the president of Sri Lanka Medical Nutrition Association. And regional coordinator for Iodine Global Network. So I welcome you, Dr. Renuka, for your talk. Thank you so much.
Thank you so much. First of all, I would like to thank Mrs. Poonam Tiwari, I think head of the dietetic department, who has invited me kindly for this session. Then all the organizing committee, as well as all the speakers. I think I was here in the first session. It was really wonderful. And for the all the participants. I'm really trying to share my thing. I hope you can see it. So I think Mrs. Poonam has given me a very tough kind of title of the today's speech, that is evidence-based nutrition, promising way ahead in patient care. So it was a bit of the tough topic. I think as keynote speakers, we had to handle the bit of the tough topics, as Mrs. Anuja was telling the same thing. So let's look at the kind of look at our scenarios, and when we really look at the long time ago. So the nutrition was kind of very simple things, but still there were a lot of lives were lost. But in that scenario in the past, we were really looking at the severe micronutrient deficiencies, and it was treated with a particular kind of nutrient. So as example, like scurvy, we treated with vitamin C, beriberi, rickets, creatine, pitot spots, koilonychia, neural tube defects, because we have been looking at the disease condition, and then we have been really treating it. So that's the kind of nutrition that has been really practiced long time back. But at the same time, some of the other practices like diarrhea. So the first few days of the diarrhea, patients were abstained from the solid foods, and they were really fed through the rice infusion. I don't know, must be something like porridge in Indian aspect. So a lot of children died due to dehydration. So similar stories which came up with the other diseases like fever and the other cough and cold and all these things. So that's a kind of long time ago, how we practice nutrition. So when we really look at in 1968, Dr. Wilmore and the Dr. Dadrick, so they came up with the kind of first report of intravenous feeding, and that was kind of breakthrough in the medical care. So that's I think that's the reason Dr. Dadrick was really honored with this type of kind of first person that who starting up this nutrition within the medical care. Since then, actually, this nutrition support has been really becoming in the kind of standard tool in the care of patients in the most of the countries. And I think most of developed countries, it has been entangled with the gastroenterologist. And then there were different kind of nutrition physicians came up in the other countries with their nutrition team, which was really hung up with the dietetic team, and then the nursing team and the pharmacist team, and like that. So many people have teamed up as a nutrition team. So, but still that it came up at the standard care of the tool for the patients. But at the same time, currently, we have to deal with another component, that is anecdotal stories. So, which is something really coming up very fast during this COVID era. So, there are so many, lot of unqualified people on social media. They do not have much training in nutrition, or with the limited training, they advise personal or anecdotal stories. So if I take one example, if I quote, so in the one Facebook post, that person says, I went on a detox diet for 7 days, lost weight and felt great. Look at my wonderful Instagram photo of me drinking green juice. So you should do it too, and you will look like me, unquote. So actually, when you really look at this quote, but the truth is, as a nutrition people, we know the truth is detoxing on green juice for a week will leave your body lacking in protein, vitamins, minerals, and finally, detoxing is for longer than this will lead to deficiencies. So this is another antidote and Anecdotal advices are not evidence-based. So they are very low quality. So let's see what is this evidence-based nutrition. So under the evidence-based nutrition, it is a kind of very integrative approach which actually combine three aspects. That is clinical expertise, entangled with the best scientific evidences available, as well as we have to consider the patient's values. This is very much important. Finally, when we are taking the clinical decisions about individual patient care, we have to look at the patient's values. So all these three aspects we consider as evidence-based nutrition. So actually the aims of this evidence-based nutrition is to provide the most effective care based on the best available evidences and guiding the clinical decision making and aiming finally to improve the patient's outcome. So this is all of our final thing is to improve what we do, all these things finally to improve the patient's outcome. So under the evidence-based practice, now we are talking about the three things, that is clinical expertise, best scientific evidence, and the patient values. So under the clinical expertise, there are mainly three categories like that you need the education. I think during the last session that you have been really talking about education, number of years and all sort of things, as well as skills and years of experience. All three things will deal with the clinical expertise. And the best scientific evidence, this is something nowadays we have to really consider, because it should be relevant, because a lot of new things are coming up and it should be current. And some of the things must be very old, but it should be tested as in the current way. And the sound methodology, this is very much important. And the third factor is the patient values. And under the patient values, I think this is something very important for all of us to consider always. That is characteristic of the patients and the patient's circumstances as well as patient's preferences. Sometimes we always forget the patient's preferences. Sometimes as clinicians, we kind of look at the other way. But these three things has to go hand in hand when we are looking at the evidence-based practice. So in that sense, when we look at, there are four basic elements of the evidence-based practice. First element is, first we have to formulate the clinical questions. Then we have to find it out what is the best available evidences. Then we have to assess what are the validity of these evidences, because all these evidences may be not valid. So is there internal validity or the external validity? And then applying these evidences, we have to make the practice. And then in conjunction with the clinical expertise, and it should be joined, it should be mixed up with the clinical, blend with the clinical expertise and the patient's preferences. So let's see, formulating the clinical question, how do you do it? And under the formulating the questions, we have to have the two types, that is a background question and the foreground question. Under the background question, we have to see what is a general knowledge to address patient care. And the foreground questions always look at it as a PICO. PICO is we always consider the particular patient. And then under the PICO, P is patient or population, what is the problem? And the intervention, comparison and outcome. All four things we have to look at under the foreground question. So if I give you an example, what is the background question? If we see what patient characteristics are associated with an uncontrolled type 2 diabetes. So that is a background question which come to us in the clinic. So what is a foreground question? So does consistent carbohydrate diet improve glycemic control in a middle-aged Asian woman with type 2 diabetes? So that's a second level of the questions. So under that, what is a PICO? PICO is patient, that is a middle-aged Asian woman with type 2 diabetes. And I, intervention, it is a consistent carbohydrate diet is the intervention. Comparison, so we are comparing that group with the no specific diet. And the finally outcome is, we look at the HbA1c levels, whether it will get effect. So that's a way that you have to look at the first element. So let's see the second one, that is how are we going to find the best available evidences? So under the best available evidences, there are three types of things we have to look at. That is the type of publication and the date, as well as population characteristic. Because some of the populations are meant for the pediatric population, not for the adults. So you have to look at the population characteristic. So under the publication type, I will give you the next slide in detail. So there are high level of evidences because it may be just observation study, it may be just a kind of cross-sectional study, but you have to always look at the more solid, higher level of evidences in this publication type. And the other thing is a date. This is very much important. We can't really talk about 1976 research and the 90s, 80s one. So it should be kind of out. It should not be an outdated one. And it's better to really go for the most recent evidence available. This is very much important. And the population, as I mentioned you, and the age, gender, both aspects are very important. So under the best scientific evidences, usually you look at 4 types of research. One is clinical practice guideline. So the lot of clinical practice guidelines were developed according to looking at the systematical reviews, and these are developed systematically and the guiding, getting the lot of clinical expertise. And these are for the assisting clinicians and especially for the patient's decisions and the clinical circumstances. And then the next one is meta-analysis. And we know that what is meta-analysis? Meta-analysis is a systematic review that you look at the quantitative method and then summarize the results. And the most important other scientific evidence is the randomized controlled clinical trials. Sometimes it is a big problem with the dietary aspect because it's a kind of very challenge that we are facing with the diet with the randomized control trials, but still that there are some research are available, and there that we look at the over time that how is our outcome is getting changed. And the systematic reviews are the things that which is used most of the time, because these are the kind of, we summarize the this medical literature and the critical appraisals and all the individual studies, and then look at the appropriate statistical techniques to combine these valid studies. So as example, if I look at these best evidences, now the problem we look at lipid management with diet and dietary supplement. So the resveratrol. So you know the wine that every time the red wine is really recommended for this type of thing. But what is the kind of scientific evidence with the red wine and the resveratrol in the red wine? And according to the new literature, it says lipid lowering effect was really described in the experimental and the cell culture studies. But in the randomized human trials, it is less conclusive. So that means that we can't really put it into as a kind of evidence-based intervention. And then the other one is the garlic. So even the garlic for the lipid control, and this is also the smaller trials, they have given the benefit of the garlic supplementation. But after that, there were subsequent large trials. They have not demonstrated the improvement in lipids in the different garlic preparations like raw, powder, or aged garlic. But at the same time, there are some positive things. This is psyllium. And in the meta-analysis of the randomized trials, actually, this is one of the wonderful things. Even the psyllium we are getting from India. I think it is mainly available in India. And it shows that both normal and the elevated cholesterol levels, and especially getting 10.2 gram per day of psyllium, which will lower the cholesterol average 12.8 milligram per deciliter. So this is something, the very solid evidence. So this is what we have to always look at when we are practicing, what are the best evidences available to improve the patient outcome. So the third element is assessing the validity of the evidence. And when we are looking at the evidences, usually it goes with the grading. We know that every time with the guideline preparation and even at the any evidences, when we are looking at, we have to see whether it is a grade 1, 2, 3, or 4. So the grade 1 means it's a very good, and because these evidences are coming from the coming from the very good high quality studies, and then it has a generalizability also. But the grade 2 means these are fair, but these studies are strong study designs, but there are some methodological problems and the inconsistencies as well as the generalizability of the results are also the issue. But the grade 3 means those are limited, and these studies are really weakly designed and the inconsistent results. and there is a doubt with the generalizability also. And the grade 4 is mainly coming with the expert opinion only. When you don't have studies, so then that when the experts get together and they go looking at the conclusion of these studies, mainly based on the something, whatever the available research studies, they take and get the expert opinion. So this is what the grading is going with the, to find the validity of the evidences. So let's see the example. If you look at the nutrition therapies. So the grade 1 recommendation evidence is oral nutrition intake shall be continued after surgery without interruption. I have been really listening to the critical care person, and she was telling that even with the 200 ml of gastric volume, that they stop the feeding. So by the nurses in US. So this is what I mean. This is the you have to really look at these evidences, and this is the kind of grade 1 evidence they say that you have to really. I mean, this is one of the example. At the same time, that should not really depend on the bowel movements or less than 500 ml of gastric residue. And the grade 2 one is, for the example, is a non-critical ill post-operative patients who are adequately nourished, not to initiate parenteral nutrition prior to 5 days post-operative. I mean, this is something, another grade 2 kind of recommendation. And the grade 4, grade 4, like the clinical expertise and the scientists' expert knowledge, they provide the upper tolerable intake levels of like molybdenum and that kind of micronutrients, because there are very limited research available on that aspect. So in that sense, then the grade 4 kind of recommendations are given, evidences are being taken for the practice. So the fourth one is how are we going to apply these evidences in practice? And then it should be a kind of blend with the clinical expertise and the patient preferences. So we have to look at how closely these findings are resemble with our patients or his problem, and whether this intervention is feasible for this patient, or whether this intervention align with my patient's values and wishes. All these 3 aspects we have to really look at when we are applying these evidences in practice. So as an example, now it's something like evidences when you take a woman with the chronic pain from the terminal and untreatable cancer receiving only palliative care. So she developed, during her palliative care, she developed impaired glucose intolerance, and she is now in a high risk of type 2 diabetes. So according to the evidences, diet and lifestyle program reduces the risk of type 2 diabetes. So in this patient intervention, what are we going to do? So looking at the patient's preferences, looking at the patient's condition, her comorbidities, as well as the social setting, we should forego such a restricted diet. So this is what, though the evidences are there, we have to, when we are practicing it, when we are applying it, we have to think about that component. So at the same time, that it is very important to, I mean, as a team in the clinical hospital settings, we have to change the clinicians' practice behavior also, because this is not a one person's thing, because we are working as a team. So everybody in the team should know that what is going on, what are the new evidences, how it improve the patient's outcome. So with that, we have to really do the kind of changing of the things, practice behaviors, kind of doing the education. So the passive and active, or maybe the change in the working environment, like the managers, and then the feedback on performance. These are very important. And the clinical practice guidelines, I think these are really important, because these are authoritative recommendation, and you can always influence anyone with the good clinical practice guideline. And because these are very evidence-based rational guidelines, and the local opinion leaders, maybe respected colleagues, can really put it into the network and the persuasion. At the same time, put in the economic incentives and the things in the, sometimes it can be really entangled with the insurance and everything, or the change in the patient's expectations, kind of like media and all sort of things. So this another options we have to really look at whenever we are changing the practices, because changing is not really easy to do in our settings. So in all these things, So what is our future? How we are going to really practice evidence-based practices in the nutrition care? So one thing is we have to adapt these 4 steps of evidence-based practice into everyday practice, and not only to improve the patient care, but to empower the nutrition teams, which is very important. At the same time, the traditional long-term nutritional practices in the society, which may have a lot of beneficial effects. So, however, these practitioners have a challenge to convert it to the evidence base. So that is also very important to look at in the future, because our South Asian countries, Asian countries, we have a lot of kind of traditional things in our societies. So we should really look at whether those things are beneficial, and then how are we going to make it evidence-based. This is very much important, rather than telling that these things are not good and things. I think there are something in these traditional practices. At the same time, we have to understand the optimal use of nutrition therapy in this highly complex, and especially in the timing, route of delivery, and the amount and type of nutrients have to be considered, and especially that which really give the good effect for the patient's outcome. And then another newly thing, one which coming up, I saw that last session that a lot of speakers, they came from the wellness category. So the nutrition related to wellness, I think that's another component have to be understood by the nutrition teams in the future, because that's a kind of good scope in the future. So with that, thank you very much for your patience listening. And finally, I would like to thank Mrs. Poonam for inviting me.
Thank you, ma'am. Thank you. It was so enlightening. And actually, you said correctly that this topic is very new and we really need to practice. And the way you have taught us, you have made it's in a flow chart. Like you have to do this, you have to do this, you have to do this, and you will achieve the evidence-based nutrition practice. So thank you very much, ma'am, for making such a complex topic in such an easy way you have explained us. I'm really thankful to you, ma'am. Thank you very much. Now I would request Shreya to please share the slide. And our next speaker is Archana Sinha. She's senior dietitian from S.D.C. IIMS Lucknow, and a very well-known name in the field of renal nutrition. The prize awarded, she has been awarded the best paper in national conference, first, second prize, 20 publications, IDA President Award at National Institute of Nutrition, Hyderabad in 2008, twice winner of Audio Plus Award for the best research paper in the field of renal nutrition, first prize, oral paper IDA Con 2016, second prize IDA Con oral virtual conference 2020-21, best dietitian award under Best Employee Award at Silver Jubilee Foundation Day celebration at SGPGI on December 2014, nutrition expert at Doordarshan, DDUP and CMS Radio City, lifetime membership of IDA, lifetime membership of Indian Society of Peritoneal Dialysis, executive member of Kitchen Monitoring Committee of SGPGIMS, executive member of Kitchen COVID Committee. Oh, Archana, you had been dealing with so much of work and still you have taken out time for us. I'm really thankful to you. Only request that the time constraint has come all of a sudden. So I would request all these speakers to please adhere to the time limit. And so here we start. Archana, over to you. Thank you.
Let me share my screen.
You can share your screen, Archana.
Yeah, I'm sharing. Just give me 1 minute.
Shreya, you come out of your screen so that she can share.
Is it visible to everyone? Is it visible to everyone?
Yes, Archana, you're audible also and it's visible also.
Thank you. I'm really very thankful to Poonamji and the team Dietetics, RML, for giving me an opportunity to present my talk, the diet in CKD and dialysis, and how to plan a patient-friendly diet. And this is very, very important. And we all know that the nutrition care of the CKD patient is very complex. So, but being dietitians, we can play an important role in increasing the nutrient intake of these patients by making a making diet very realistic, which they can easily follow. So today we'll discuss certain important points that we should take into consideration while making the tailor-made diet charts for all these patients. So I'll start my slide with asking you a question. Is nutrition counseling or giving an individualized diet chart to these patients important? Yes, I guess everybody will be very much agree with me that this is really very, very important. So many centers lack a dietitian. In spite of this fact that nutrition is very important, most of the centers, they lack a dedicated dietitian and seldom an attempt made to improve the nutritional status. And for making diet charts, we should also know that there are certain problems which is unique to the CKD patients. Like these are predominantly vegetarians, more number of patients diabetics, and more there are more incidences of the inflammation and infection in these patients. And these patients are also associated with more atherogenic lipid profile. That's why more cardiovascular involvement is there. And sometimes indiscriminate dietary protein restriction is being placed in pre-dialysis stage. And sometimes we also see that there are some there are self-imposed restrictions. Sometimes there are family-imposed restrictions because of the several myths and misconceptions related to the diet. So this is a time when we play an important role for clearing all these myths and misconceptions related to the diet. And gastroparesis is also very pronounced, especially in the diabetic CKD patients. Late initiation of the dialysis is mute yourselves.
Please, may I request the others to mute themselves? It's creating problem for the speaker. A humble request, please mute yourselves.
Thank you. Sometimes you also see in Indian scenario, there are late initiations of the dialysis. There are sometimes inadequate dialysis is also very important. That leads to more uremic symptoms, and these leads to the inadequate dietary intake. And so the patient land up and start the dialysis at a very malnourished stage. Most of these issues can be mitigated through a patient education, nutrition screening, assessment, and proper nutrition intervention plans. So we need to clear all these myths and plan a patient-friendly diet. The aim of our diet should be to prevent malnutrition and to prevent and treat any comorbid conditions if it is there. The good meal plan with appropriate dietary choices will help to minimize the uremic toxicity and the fluid buildup between the dialysis treatment. And it also helps to improve the nutrition and functional status of the patient and to preserve lean body mass. But we have to remember that there's not a fixed or standard renal diet chart. It has to be individualized for each and every patient. So for making the various nutrition requirement, the body weight estimates are very, very important to calculate a dietary intake. And it is reasonable. The guidelines suggest that it is reasonable to use the clinical judgment. We have to decide whether we need to use the actual body weight or the serial or longitudinal monitoring of the weight, or history of weight change is also very important, whether the patient has lose weight, gain weight, or there is no change in the body weight. In the absence of because there are not some standard reference norms for Indian CKD patients. So if there is no change in the body weight, then blood pressure is a very good clue. If patient has having uncontrolled BP or has developed the CHF, then fluid overload is there. So you have to be careful, and you have to remember that for the MSD patient, we have to take the post-dialysis weight, and for the peritoneal dialysis patient, we need to consider the post-drain weight. And now for the patients who have their edema-free body weight less than 95% or more than 115% of the median standard weight, then edema-free, gestate edema-free body weight has to be used to have, so that we should not over-calculate or less calculate the nutrition requirement for these patients. Now, according to the DOKI guidelines, the calorie for the patients who are less than 60 years of age, 30 to 35 kilocalories should be there in the diet. And for the patients who are more than 60 years of the age, the diet should be between 30 to 35. And calorie restrictions are further needed for the patients who are overweight, obese, or who are having a more sedentary lifestyle. The latest guidelines 2020 on this clinical practice guidelines, they have suggested to use a calorie intake between 25 to 35 kilocalorie, depending upon the patient's weight, the weight loss history and body composition and their physical activity level. Now for the patients, like the patient who are on peritoneal dialysis, and as we are aware that the peritoneal dialysis, the dialysate is dextrose or the glucose base. So it is very important to take the PD calorie load. We have to calculate it and add it to the total calorie intake of the patients, as we know that the approximate energy absorption from the dialysate is around 78 calories from 1.5% dextrose solution and 130 calories from 2.5% and 221 calories from 4.25% of the 2-liter solutions. And now assessment of the energy and protein intake, then the guidelines suggested that ideally we should use a 3-day diet recall conducted both on the dialysis as well as non-dialysis patients as a preferred method. However, in the if the person is not having much time, then at least 24-hour diet recall, food frequency questionnaire, or sometimes the most sophisticated methods like NPCR can be taken as an alternative method for calculating the dietary intake in these patients. But we have to remember that symptoms like anorexia, nausea, vomiting, their dietary habit, their dietary pattern, frequency and timing of the meals, quality and quantity of food ingested, and the fluid balance in these CKD patients, this has to be very carefully and properly evaluated so that we can compare it with the recommended intake, and then we can fill the nutrition gap by the appropriate dietary counseling. Now for the CKD patients on conservative management, not too little, not too much of protein. We need to keep into the mind, because as we have already discussed that majority of the patient being vegetarian and they consume much less protein than recommended by the ISMA guidelines. So protein restrictions should not be routinely advised without estimating their protein intake. So not only the quantity, but the quality of these protein is very, very important in these patients. And we need to specify the various cooking methods to these patients also, so that the protein should not get denatured. And now, if the protein is restricted, it is very important to provide enough calories in the diet to provide the protein sparing effect and to maintain the nitrogen balance. And for the patients who are not on dialysis, a low protein diet of 0.6 gram per kg per day should be considered. But how for the patients who are not able to maintain on such a diet and they are not able to maintain adequate energy level, then a protein intake up to 0.75 gram may be prescribed for these patients. And for the patients who are diabetic, 0.6 to 0.8 gram per kg body weight is needed to maintain the stable nutritional status and to maintain euglycemia. Like earlier guidelines, they have suggested that 50% of the protein should be from the high biological value. However, the latest guideline, they have suggested that as there is not so much of evidence to recommend a protein type, whether the animal protein or the plant protein, in terms of their effect on the nutrition status, phosphorus, the calcium and their lipid profiles. So based on the preference of the patient for animal or plant protein, we need to ensure that they meet, whether they are having animal protein or plant protein, they have to meet their dietary protein energy needs, and diet should provide all the adequate essential amino acids. So a judicious combination of plant-based protein plus animal protein can give will help to meet all the macro and micronutrients after making adjustment for the electrolyte. So we need to assess the actual dietary protein intake in these patients and allow a vegetarian patients to continue with their regular diet with no restriction of protein if it is coming within their calculated limits. And now for the patients who use non-veg foods very frequently, we need to assess the diet, and we can allow them to go for the non-veg foods in the frequency and amount is specified by or calculated by us, while making the balance of phosphorus, potassium and other things. And we need to look for any self-made restrictions for these patients. And for the patients on dialysis, a protein intake of 1 to 1.2 gram per kg per day has to be given. And now, as we have discussed, majority of patients are diabetics. So for the patients who are at the risk of developing hyper and hypoglycemia, some higher level of protein can be given for these patients to maintain euglycemia, and the patients on PD, if they are having any type of infection, the peritonitis, then further protein can be given to them. Now for the patients who are diabetic, as we know that carbohydrate is the major determinant of postprandial blood glucose levels. So the amount and the quantity, means the quantity, quality, as well as the frequency and timing of carbohydrate is very, very important. So for the patients who are on fixed dose of insulin, emphasis should be placed on keeping the amount of carbs constant at each meal. And regular meal timing is very, very important. So we need to assess the dietary pattern of these patients also. And now fat is always looked as a villain. So there is nothing like ubla hua khana for our patients. And for the patients with dyslipidemia, we have to remember that the National Kidney Foundation, they have suggested that the dietetic approach to dyslipidemia and CKD patient is always similar to the patient without the CKD. So if the patient is having some degree of dyslipidemia, then we can go ahead with the American Heart Association guidelines, the step 1 and step 2 diet. And we have to remember that we need not to restrict the fat totally, because essential fatty acids are very much needed in our diet. So at least 2 to 3 teaspoons of oil and ghee has to be given to them. And plus the judicious combination of various cereal, pulses, vegetables, milk, and different type of vegetable oils can help us to maintain our diet and the desirable ratio of polysaturated to saturated fats. And now the protein is restricted, so we have to maintain the adequate energy to prevent the malnutrition and to have at least, if we are not land up with the positive nitrogen balance, we can have the neutral nitrogen balance. So small frequent meal is the key. And we can use the sago in the diet depending upon the patient taste and amount. We will decide depending on patient is diabetic or else. In some places of the India, patients are very they are very happy to use arrowroot, sago, rice flour to the wheat flour. But for our patient in North India, we can use these things if it goes well with our patients. We can use ghee and dal, the chapati to increase the calorie content depending upon the total amount of fat we are giving to them. Desserts can be prepared for the non-diabetic patients, and sago, the important thing is that it is low in protein as well as it has a very low negligible amount of phosphorus. But for the diabetic patients, we have to control the portion size. Now potassium is one of the important mineral which has to be considered in the management of CKD patients, and the guidelines suggest that we have to adjust the dietary potassium intake to maintain a normal potassium level. And always whenever we are counseling a patient, we need to rectify the causes of we have to identify and rectify the causes of hyperkalemia where the patient is having. We have to review the patient, take a good diet history and review the medicine prescription the patient also to have some clue. So the excessive intake of potassium rich foods, so chronic constipation, sometimes hyperglycemia, very low GFR could be the possible reasons. Sometimes patients are using salt substitute, which is very rich in potassium. And if they are taking some ACE inhibitors or ARBs, we have to take all these things into account. Now we can help a patient to choose the low potassium and low potassium fruits and vegetables. But it is seen that sometimes leaching is suggested to each and every patient of CKD. That should not be done. Leaching is needed for the patients who are having some degree of hyperkalemia, that too for the short span of time. And this is not needed for all the patient all the time. Now hyperphosphatemia, this is the major challenge in the CKD patient. And so dietary counseling is very, very important to increase the awareness and knowledge of the patients regarding the various phosphorus sources as well as their bioavailability, because both the animal as well as plant protein, they contains organic phosphorus, 40 to 60% of which is being bioavailable. But the bioavailability of animal protein is more, around 70% compared to less than 50% of the phosphorus sources in plant-based foods because of the phytase, which is not readily available. And some of the carbonated beverages, meat, frozen milk, the processed and spread teas, instant food and processed food products and bakery products, they contain inorganic phosphorus, more than 90% of which is bioavailable. And the phosphorus bioavailability from a typical mixed diet is around 55 to 70%. And the phosphorus from additives, we have to remember this thing, that phosphorus from additives are almost 100% bioavailable to the body. So we need to teach our patients to look for the food labels, look for the phosphorus, or look for the phos in the ingredient list. So now, one of the important thing, the guideline has suggested to use the matrix phosphorus to protein ratio for managing the hyperphosphatemia. These matrix also help us, these composition table also help us to choose the diet which is low in phosphorus without restricting the adequate amount of this protein. So as we can see these from this table, that egg white is the lowest, is having a lowest phosphorus protein ratio 1.46. So we can allow this to our patients. So these helps in restriction of non-protein sources of phosphorus, and it is most effective in managing the hyperphosphatemia as well as managing the malnutrition. Now, so the therapeutic strategies for phosphorus control focus around the judicious restriction of dietary phosphorus. Not only we need to see the quantity, but also if it is less bioavailable and this is helpful, then we can allow it to our patients. And now next, as we know that even the phosphorus is not very easy to remove, so adequate phosphate binders should be used for the meal within the meals. So जब हम patient के counseling करते हैं, तो then we have to tell them कि you need to have these phosphate binders with meal only. वो 2 घंटे बाद ले रहे हैं, तो it will not have any effect. Or adequate dialysis are very, very important. Fortunately, there are methods like soaking of foods in water and boiling, which significantly decrease the dietary phosphorus content. Around 50% can be removed per gram of the protein consumed. For more detail, you can read my article published in Clinical Query Nephrology. Now, sodium. Sodium is very, very important, and guidelines suggest to restrict the dietary sodium intake less than 100 millimole per day or less than 2.3 gram per day to have optimum blood pressure, improve fluid load, and to reduce proteinuria if it is there, and to have more desirable or maintain the ideal body weight. Now, one important thing I need to suggest that what we are doing, we need to look after the dilutional hyponatremia, because serum sodium is not always a reliable or true indicator of the sodium intake in CD patients with fluid overload, because the fluid retention can dilute an elevated level. So rather than just giving the salts, extra salt, we should also look for the fluid restriction in these patients with dilutional hyponatremia. So these patients should be, in these patients, the serum level must be evaluated in combination with the fluid status also. Now, since salt is restricted, so we can allow a patient to use certain spices, herbs, and condiments to enhance the flavor and make the diet more palatable. And day one से patient salt restriction नहीं कर सकता, पहले आपने assess करना है how much salt is or she is taking. Then we teach them to reduce the amount of salt in cooking and preparations of meal over a period of time. And whatever food they are cooking should be prepared from fresh ingredients. And then they can cook the food without salt and a prescribed amount, or use only the prescribed amount of salt and do not add other things. And apart from salt, the other dietary sources of sodium like achar, papad, chutney, processed, canned, dibba, short of foods, and meal prepared with monosodium glutamate, because the table salt we are using is 40% by weight, and the MSG is 100%, is having 100% sodium. So we have to be very careful. Now I'm just scrolling through small tables having the sodium, potassium, phosphorus level of some commonly consumed food by us. This is based on the 2017 IFCT data. We can see that the sodium, potassium, and phosphorus level of dhuli versus the sabut dal is more or less similar. So not much difference according to new IFCT data. And as we can see that the common spices like turmeric, jeera, hing, methi seeds, and long can be used for these patients to enhance the flavor. And the coconut water, bale fruit, and potato is high in potassium, so we have to be a bit careful. And now the green leafy vegetables like spinach, bathua, chalai, methi, saag, they are high in potassium, so need to be restricted. I have already converted these value to MEQ as the normal requirement of potassium for these patient is 1 MEQ. So जब हम साग खाते हैं तो 250 ग्राम साग बनाने के बाद एक कटोरी होता है, तो we have to be careful about the portion size also. And egg white is very low, so we can allow this to our patient. And again, the roti with chilka.
Archana, only 2 minutes left. I'm just helping you out to wrap up the session. Thank you, Archana. Thank you.
I'm just going to complete it. And so the potassium content of commonly things like we can see that the bina chokar wala atta ki roti is around one roti will give 25 gram ki one roti will give 1 MEQ, while chokar wala atta ki roti will give you 2 MEQ. So after seeing these tables, we have to we can say that spices and condiments can be used after quantifying their potassium content. So portion size is very, very important, and we desperately needing the various studies in Indian data regarding the bioavailability of potassium in foods and their effect on cooking and washing and leaching and all, and calculate what are the changes between if we are using the raw values to the cook. And leaching, we have to, otherwise we have to remember that leaching is not always needed for all the patient all the times, because it will also result in the leaching of the water soluble vitamins in these patients. So first we need to calculate the protein in terms of their quantity and quality, choose low phosphorus diet, fix calories, then we can decide the amount of roti or the dal or milk and milk products and eggs. So depending upon the total potassium we are going to give to our patients, rest of the potassium we can calculate from the fruits and vegetables depending upon the patient's choice and preferences. And fluid requirement is very, very important. The thumb rule is to go for the previous day urine output plus 500 if patient is dry, plus 300 if patient is having edema or fluid overload. However, this is highly individualized depending upon the intradialytic weight gain, means the fluid gain during the 2 dialysis or blood pressure or residual renal function. So we have to be careful and evaluate. We need to do a physical examination to see the extent of fluid overload in these patients. Fluid intake, we take a good history to take the fluid intake. We can see the PD books or the HD record book to see their urine output, ultrafiltration. And for the MSD patient, we need to look for the intradialytic weight gain and weight gain pattern. And for the PD patients, we can see the compliance with the exchanges, whether they are using 1.5, 2.5 and 4.25. Sometimes hyperglycemia may also cause these things to get worsened, and we can teach them to control fluid loads. So nice ways to teach our patient to read the food labels, check for the phosphorus for the in the ingredient list for the hidden phosphorus, look for the sodium, look for the other things. And so to conclude, I may say that correct and appropriate dietary advice and dietary counseling is very, very important at every stage of CKD as well as the patients on dialysis. We need to clear the doubts and misconceptions and myths regarding the diet through an individualized and realistic meal plan. We need, but the important thing is that one-time counseling is not going to help in the long way. So we start the dietary counseling at the as soon as the patient come to us in the early stages of CKD and at the start of dialysis, because there's a vast difference between the diet in the pre-dialysis and dialysis stage. And also we need to counsel the patient on ongoing basis with diet diary to prevent the malnutrition. So thank you. I may say that, see, all these guidelines are like torch in the dark road, but no, we have to scale it as per the individual needs. Thank you. Thank you so much.
Thank you, Archana. You have made many things clear to even me, even like Kidoki Guidelines 2020 you have brought for all of us. I'm really thankful to you. There are 2 questions for you. I'll be happy that if you can answer them, because of the panel discussion, I might need to reduce the time of speakers. So I don't want to do that. If you can answer it, so that will help us a lot. They will get the answers even. So thank you very much, Archana, for this enlightening and informative session. Really, you have done justice to the topic. Thank you very much. Now coming to our next speaker, Prachi Chandra. May I request Shreya to share the screen of Prachi so that Prachi is there? Yeah. Prachi, right now she is heading Department of Nutrition and Dietetics at Sri Shankara Cancer Hospital and Research Center, Bangalore. And I would request Shreya to bring the slide of Prachi. This is slide of Archana. Is it possible, Shreya? Can you do that?
Yes, ma'am.
Okay, please do that. Hello, Prachi.
Hello, ma'am. Good afternoon. How are you?
I'm fine, thank you. Just a sec. Just a sec. I'm just taking 1 minute time.
Yes,
I would love to introduce you. So Prachi's topic for today's symposium is Therapeutic Onco Nutrition Theory to Practice. Having 8+ years of work experience in hospitals and healthcare corporate sector, from 2019 till date, she is heading the Department of Nutrition and Dietetics, Sri Shankara Cancer Hospital and Research Center, Bangalore. From 2013-2015, team lead clinical nutritionist, Vidya Healthcare Services Private Limited, BTM Layout and Whitefield, Bangalore. 2011-2013, registered dietitian, Columbia Asia Referral Hospital, Yeswantpur, Bangalore. 2008-2011, consultant dietitian, Our Hospital and Heart Center, Alambagh, Lucknow. She holds lifetime membership of IDA, Bangalore chapter, life membership of Nutrition Society of India, International Confederation of Dietetic Association, lifetime membership of Asian Federation of Dietetic Association, member of ESPN Society. So Prachi, with such a rich, experience and your dedication and hard work towards Onco Nutrition, now all stage is yours, and you please continue with your session. Thank you, Prachi. Thank you.
Thank you, ma'am, for giving such a wonderful opportunity. I was hearing all the sessions in the morning. It was really nice that you have come up with the concept, whatever, as per the government's theme now, from farm to fork. It's very nice, ma'am.
Yes, thank you, Prachi. Thank you, all yours.
Ma'am, regarding screen sharing,
do you want us to do, or you will be able to do? Shreya, have you given the? Yeah, Prachi has started sharing. Okay.
Yes, ma'am. Is it visible?
Yeah, it's visible, audible. Just remember for the time frame, because I was not knowing IT department has suddenly put up alarm over me. So I'm just requesting all of you. Thank you.
Okay. So, ma'am, as we all know, September is being celebrated as a cancer awareness month, especially for the blood cancer, all type of gynecological cancers, thyroid cancers, prostate cancer, and childhood cancers. So we are also trying to celebrate that in our pediatric section, especially for the pediatric cancer patients now, because they are very vulnerable. And adults, somehow we can manage easily, but it's difficult to manage the pediatric patients. So quickly, as we all know what cancer is, so I'll quickly go through the slides that when the normal cell is not, their growth is not under control, they turn into a cancer cell, and what happens is majorly there are changes in the DNA, and the normal DNA changes to oncogene. And because of that, our body's natural immune system is not able to control that uncontrolled growth of the DNA. And along with that changes that occur in the DNA due to various factors like in our environment, our genes, our exposure to chemicals and all, we gradually develop cancer over a period of time. And later, by the time we are able to diagnose it, it goes into a metastatic state where it starts spreading to other organs. So as we see, cancer is increasing in India. And if we see the global incidence, out of like all NCDs that are prevalent, cancer accounts for 93% NCDs. And especially in Bangalore also, we are seeing a very high number of cancer patients. And as per the cancer registry, National Cancer Registry also, we can make out that in India in 2020, there were 13 lakh cases of cancer. And now they are expecting 15 lakh cases by the year 2025. And the type of cancer that are prevalent is among males is more of the lung cancers, mouth cancer, esophagus cancer, and stomach cancers. Among the female, breast cancer, cervix cancer, endometrium cancer, all gynecological cancers are getting very common. And we have seen that there are a lot of demographic variations also because of the eating pattern, because of their lifestyle and all. Like if we see in the Northeast region, because of more of the tobacco consumption and household firewood consumption, they have more of the esophagus and lung cancer. In South, especially, here people eat lot of spicy food and salt-rich food like papad, pickles, and all accompaniments will be there in the meals. Their meal is not complete without inclusion of papad, pickles, and bakery items. So here we have seen lot of stomach cancer patients. It's more prevalent in South India. And like we see in the Punjab and all, because of the more agriculture area, use of pesticides are one of the causes of the cancer. So we'll just quickly go through why is nutrition important. As we know, it is important in all the disease conditions. Same.
Yeah, Prachi, so sorry to interrupt. Can you make it in the slideshow? One of the registrant has raised a question. If you can make it a slideshow. Slideshow, it's there. It's just above animation slideshow. If you can see.
1 second, ma'am.
Yeah. Yeah. In slideshow, click the slideshow, and from the from current slide, you make it from the current slide.
Okay. Okay. Is it okay, ma'am?
Yes. Yes. Perfectly fine.
So as we see, whenever there is a tumor in our body composition get altered, because again because of the changes in our DNA and all, and because of the tumor growth, our food intake goes down. Because of the tumor, many times there are mechanical obstructions. Tumor, depending on the place where it is, it causes pains. So emotions of the patients get disturbed, and all contribute to the malnutrition. So poor nutrition results in the decreased muscle mass also. Fat breakdown is also more. So because body needs energy, and because of the anorexia or the side effects of the tumor, we are not able to meet up the nutritional needs. So there is lot of fatigue, weakness, and people are not able to do their basic daily activities. So that is why even good nutrition is important for the patients, so that we can reduce their length of hospital stay and improve the overall quality of the life. Even during various treatments of the cancer, if nutrition status is not adequate, it will lead to more of the complications, and their healing will get affected and their treatment get delayed. Next is cachexia. Cachexia is very common in all the cancer patients, and it is the loss of the fat and the muscle mass. And because of not eating proper nutrients, it leads to malnourishment. It causes weight loss, loss of appetite, fatigue, weakness, and there are electrolyte imbalances along with that. And whenever there are electrolyte imbalance in the body, it leads to other complications. There will be pain for them, there will be weakness for them, numbness, tingling sensations will be more for them. And even severely malnourished patients will have trouble doing their daily activities of the life. So how we categorize cachexia? Like we, in our hospital, what we do is first we screen the patients when they come to our OPD and all IP patients. And based on the screening, then we follow the PGSGA or the patient assisted global assessment form. Based on that, we categorize patient whether they are in the pre-cachexia state, cachexia state, or refractory cachexia state. So if we see like that, pre-cachexia, generally if we don't want to go for assessment, if weight loss is if weight loss is less than 5% of the body weight, it is pre-cachexia state. If weight loss is more than 5%, then we can make sure that cachexia is happening. And if weight loss is more than that, then patient goes into refractory cachexia. And when the patient is in refractory cachexia state, there is no role of much nutrition intervention, because whatever we do, we can't bring back patient from that state to better condition. Only if the patient is in cachexia state, we can do a nutrition intervention and bring them back to the pre-cachexia or the little normal state. And so these are the basic what we see, what how the tumor progress or how the cancer progress, mainly through the diet. We see excess fat consumption, excess protein consumption, excess calories, no? And excess of omega-6 like our oil that we use for cooking. So because of that, it all leads to promoter helps in aiding the cancer growth. And metabolic changes, if we see, insulin resistance is there. Lot of, if we take lot of hormonal treatments, or because of the obesity, estrogen levels will increase. Because of this oxidative stress, inflammation, all that, they all contribute to the tumor growth. So as you see the cancer patients, once the diagnosis is made, first important thing is we have to do the nutritional screening. And we have to keep 4 things in mind: that what is the condition or what is the stage of the cancer, and the condition of the patient, whether it's a stable condition or not. And depending same on the stage, we will categorize whether the condition will get worse, and treatment, whatever they are planning to do. Along with the NRS, we can use PGSDA to get the detailed assessment of the patient. Even as per the new ISPN guidelines, GLIM criteria is better. So we can use even that also to assess the condition of the patient. So this nutritional assessment of the patient and the treatment both go hand in hand, because all patients will have weight loss, anorexia will be there for them, sarcopenic obesity will be there for them. Their intake won't be adequate because of the underlying disease process. Their body mass index either will be too high in the obese or the overweight category, or they'll be in the underweight category. Hardly few patients will see in the normal weight range of the BMI. And cachexia is the main side effect of cancer. And along with that, systemic inflammation will be there. So along with what treatment doctors are planning, we have to keep these things in mind and then categorize whether patient is at risk or not, or whether how many of these symptoms are present. And then we have to plan diet for the patient, keeping their nutritional status in mind. We have to make sure that they are physically active, their muscle mass should be retained, because all the chemotherapy drugs and their treatment and all, their dosage is based on their muscle mass. Okay, then we have to make sure whether their GI tract is functional or not. And we have to give them psychological support also. Only telling about the nutrition won't help. We have to give them psychological support also, because most of the patients, they'll not listen to you only because they're psychologically so stressed that they won't bother about nutrition. They just want to get relief from the pain. So all that we have to keep in mind along with the nutritional counseling. So this is the normal NRS form that is been approved and everyone uses. We also use the same in our hospital. So what are the most common side effects? Whether a patient is undergoing chemotherapy, target therapy, or radiation therapy, or surgery, these are the main common side effects that we deal mainly here. And most of the patients, they'll be having nausea, vomiting. Otherwise, diarrhea will be there, constipation will be there. As a side effect of chemo and radiation, 90% of the patients will develop mucositis within 1 week of post-treatment. And post-surgery, there are many patients who are at risk of getting a refeeding syndrome because their BMI will be, if their BMI is less than 16, then more chances, or if their intake is feeding syndrome will be more in them. Then all esophageal cancer patients are, once they start with the treatment, especially through radiation, they'll have dysphagia. So it will increase more. Even during the radiation, xerostomia or thick saliva, complications will be more. So we have to deal with all of them together. Many times many of the side effects will be there. So once we are planning the diet, we have to be a little more careful. And nutritional requirement, how we calculate as per guideline, it remains same even for the cancer patient, that the energy what we generally give is 25 to 30 kilocalories. Protein requirement not less than 1 gram, even if they're suffering from AKI or CKD, minimum should be 1 gram, should not go below them. Seeing if they're like, suppose if the creatinine or urea is high, we should not decrease the protein intake. It should be minimum 1 to 1.2 and up, we can go up to 1.5. We can go up to 2 gram per kg body weight also, but practically that is impossible to feed them so much. So we have to set a realistic goals. Whatever goal we are setting, we should make sure that they are able to, like patients are able to eat and we are able to achieve our goals. Fat requirements and carbohydrate requirements remain as per the other normal patients only. Salt also, depending on the if patient is hypertensive or not, we generally keep it to less than 5 gram per day. But during chemotherapy, they'll be giving diuretic drugs. So because of that, there is lot of loss of sodium in the urine. So the patient will be landing a bit to hyponatremia very frequently. Along with the drugs, their food intake won't be proper. So chances of getting hyponatremia will be more. So we have to vary our salt intake based on the patient disease condition. Regarding fluids, minimum 1500 to 2000, up to 2 liter fluids, we have to make sure that we have to give it to them. And in case of, as we know, fever, vomiting, diarrhea, or if there are a lot of losses of fluid from the drains or from the fistula, or if ostomies, from the ostomies, then we have to manage or increase our fluid intake accordingly. And as per ISPN guidelines, omega-3 should be given at least 5 gram per day. Or if you are looking for the EP alone, it should be minimum up to 1.5 gram per day. And that is considered safe also. It is not necessary to give omega only from the fish oil. We can use even the vegetarian sources also, the marine algae. Here we have seen patients, because ours is a vegetarian hospital, or we don't allow here non-vegetarian supplements, and we prefer more of the vegetarian food. So we have seen, if we are giving marine algae to the patient to fulfill our requirement of omega-3, especially in the patients who are on tube feed or post surgery, we are able to hold their, we are able to maintain their weight. Their weight loss is not that great. Otherwise, we have seen patients who are just on the normal supplement, within a week, they'll be losing 7 to 10 kgs of weight, and that is not acceptable. So we can say that including even the vegetarian source of omega-3 helps in maintaining weight of the patient. And for the oral glutamine, for the PN, there are no specific studies or there are no proven data that PN oral glutamine will help. But it will help, oral glutamine will help during the radiation and during the chemo, because all of the patients will have mucositis and neuropathy. So if we give oral glutamine supplementation to them, it helps in relieving them, their symptoms, or giving relief to them. And same way we give is 0.5 to 0.6 gram per kg body weight. And regarding antioxidants, I would say post surgery, we can give them antioxidant rich diet, but there is no specific as such specific nutrient that if we give only vitamin A.
Prachi, I'm sorry to interrupt. You're left with 2-3 minutes more.
Okay, ma'am, well, fast enough.
Okay, thank you.
We should not recommend antioxidant rich supplements post this one, when the patient is starting on chemo or radiation therapy. We can suggest them to include more of antioxidants during post surgery. So the role of IRAS protocol is important, because we have seen that if you are following a IRAS protocol, recovery of the patient is faster. They're able to mobilize faster, and the chances of readmission will be less. So main thing is what we have to do is we have to make sure that the patient is following a high protein diet if we are following a IRAS protocol. from theory to plate, like we have to make sure that our diet is balanced. One, like we, as per the our plate guidelines, half of it should be, 50% of it should be vegetables, both cooked and raw. Same way we tell them here also during cancer also, you can include the same way. Rest 25% should be whole grains and cereal, and rest 25% should be a source of protein, whether vegetarian or non-lean meat they can include. And during chemotherapy, it is important to follow a neutropenic diet, because we have seen the patients who are not following neutropenic diet, chances of them, because of the weakened immune system, chances of them getting infections are more. So we prefer here patients to follow a neutropenic diet, but it's not strict neutropenic also. What we call is partial neutropenic diet, where we allow them to have curd, freshly prepared curds, fruit with thick skin, wherein in normal neutropenic diet, if you say they are not supposed to have curds and all that, so we follow a type of a partial neutropenic diet during chemotherapy. Only for the patients who are counts are below 500, and for BMT patients, we tell them to follow strict neutropenic diet. Same, there are many type of surgeries in cancer: curative, preventive, staging. So the main basic principles will remain same. Only thing is, based on the place where surgery is happening, like with head and neck cancer surgery, or a thyroid cancer, or a pancreatic surgery, accordingly, depending on the organ, we have to modify our nutritional intake and things that we need to consider. So type of intervention, as many speakers have discussed earlier, it is same only. There are no major changes in that. Mainly, we have to make sure that if they're suffering from anorexia or anxiety, or symptomatic management is more important for the cancer patient. So we have to suggest them accordingly, like we suggest to other patients. Same thing we can suggest to them also. So these are the management only now. Dysgeusia is like taste alterations are very common for cancer patients. So we have to make sure, we have to tell them, if we are getting a metallic taste, don't use plastic, use plastic plate, don't use metal plates. Now you have to make sure that you can add different flavors to change the taste of the food, change the temperature at which you are eating, try to have small and frequent quantity. Using supplementation also helps in improving your loss of taste sensation. So these are the basic things that we tell them. Even xerostomia, we have to make sure that they keep sipping liquids frequently. We have to modify their diet. We should not tell them to have more fat-rich diet, because it will stick to their palate. So it should be more of a semi-solid diet, or the foods which are dried, like biscuits and wafers which stick to our mouth. We have to tell them to avoid them once they are having xerostomia. And we have to tell them to avoid intake of caffeinated beverages also. Same thing in mucositis also. We have to modify the diet consistency. We have to tell them to avoid foods that are too spicy or too salty or too sweet, because again they'll irritate their mucus lining and it will be difficult for them to eat. Already their intake will be poor. So same symptomatic management, we have to tell them to include more liquids in their diet. They can change, again the consistency of the food should be changed. So same things we have to tell them. Again, constipation is a very common problem, as we know. So same we tell to cancer patients also, we should have more fiber in the diet. We have to be behind them to increase their fluid intake, because that they won't get thirst as usual like other patients. So we have to make sure that their fluid intake is maintained. It should be consumed. Diarrhea management also remains same as in other patients. If severe diarrhea is there, then we tell them they can go out and try for a BRAT diet. Otherwise, normal restriction like fiber restriction of fiber, lactose and fat, same thing we have to tell and limit. They have to strictly limit the intake of caffeine-rich foods. So all these restrictions will remain same. Apart from this thing, we have to make sure that we have once the patient is in palliative care or end of life care, as per their like satisfaction, because once there is an end of life care, there is no role of nutrition intervention. And once we are taking dietary consideration for surgery, we have to make sure that we have to consider comorbidities also along with that. And we have to make sure that we counsel them regarding weight gain, because post surgery and post chemotherapy, when the treatment is over, they should not weight gain, because more weight is also one of the risk factors to cause the occurrence of the cancer. Diet for cancer survivors is like a rainbow diet. We have to make sure that they eat rainbow colored more fruit and vegetables in their diet, so that chance of recurrence can be minimized. And myths are very common among the cancer patients, like they should not eat sugar. 2 to 3 teaspoons of sugar in a day is allowed.
I would request
but we
you
have to base cold drinks and all. So
Prachi,
ma'am, this was the thing, myths and all.
Yeah.
Thank you.
So sorry, Prachi, the
No
time
problem,
bomb
ma'am.
is there.
It was a long
Thank
slide,
you.
na, so.
Thank you. Thank you, Prachi. Thank you very much for this informative session, Prachi. You made many things clear to us. Like we always find that cancer patients are underweight, so we start giving them more of calories and protein, but we have to remember that if they regain, there is overweight incidences, then that might lead to reoccurrence of cancer. That was something very new. Thank you, Prachi. Now I would request Shreya to share the slide of Dr. Avantina Bhandari. You must be quite familiar with this name since morning, and since the inception of the symposium, she had been there helping us out with many technical issues and with many speakers. You know, she has really worked hard with me, and thank you, Avantina, for being there. She is a wellness advisor. She is a PhD nutrition postdam Germany, DAT scholar, ex-adjunct assistant professor, City University, New York, USA. And today the topic which she is going to cover with us is Geriatric Nutrition guided by 3A, approachable, accessible, and affordable. So I would request Shreya to share her
I think
PPT.
Prachi would have to stop sharing.
Prachi, can you stop sharing your screen?
Ma'am, it was showing pause. I paused it. There is no other option to close it.
No, there must be some option, Prachi, to you see there. They must be saying stop sharing screen. View option.
Yes, ma'am, I got that.
Okay, thank you. Okay, so Dr. Avantina is wellness advisor. She has a passion for communicating facts about health, food, and wellness to people. Her wellness advice is based on an approach she calls the DES approach: diet, exercise, stress, and sleep. Each component holding an important place in wellness. Very true. She has worked in the City University of New York, Global Forum for Health in Geneva, and India in both academic as well as public sector. She loves to write on health and nutrition issues. Some of her books are textbooks of food science and technology, principles of therapeutic nutrition and dietetics, food product development, healthy recipe guide, and basic plant pathology. Besides this, she has contributed numerous popular chapters and research papers to many journals, books, and magazines. She is the recipient of the DAT Scholarship and DST Award for Meeting of Nobel Laureates and Students in Lindu, Germany. If I'm wrong, please rectify me. Being creative, she utilizes her time to develop therapeutic recipes for the benefit of one and all. Being a globetrotter, she loves to travel and sample ethnic dishes from those regions. This helps her to combine unique ingredients from global cuisines and make innovative recipes appetizing to the palate, which being healthy at the same time. So we definitely need to visit you, Avantina, because now you have a Khana Khajana recipes with you. Okay. So now over to you, Avantina, for your presentation. Thank you, dear.
Thank you so very much for your very kind and gracious introduction. You have always been a source of inspiration for me and countless others. So it's wonderful to share the platform with you, as well as such wonderful luminaries that we've been hearing since morning. The sessions have been absolutely amazing, highly informative and charged. And I've been thoroughly enjoying the sessions, and this scientific session too has been very interesting in the fact that we've tried to seed new ideas in people, in our budding dietitians and nutritionists.
So one second, Avantina, I would interrupt in between because this was a very important information which I missed out. You know, when I was sharing all the topics with everyone, which topic people will take, this geriatric nutrition topic was left, and then Avantina said, I'll do the justice to this topic. Geriatric nutrition, the most ignored, part in our country. And I'm thankful to Avantina that she has taken up this, and I hope you will definitely do justice to it. Thank you, Avantina.
I will definitely try, because I think it's very important to go forward, and what Madam Renuka has set the path as to how evidence-based nutrition is so important, and it should be included in our dietetic practices. Pardon me, ma'am, I was referring to you again as Dr. Madhu Sharma, so I would now say Madam Madhu Sharma. She has also been very instrumental in busting a lot of myths. Now, as Poonam said, and we are short of time, so I would not take too much of your time. I would begin with the presentation. And as she said that I've chosen geriatric nutrition. So that is something that most often people do not think so much about. And although we do have literature, we have our recommendations, the RDAs, the RDIs, and everything to look back on and refer as theory. It is sometimes challenging to translate it onto plate or translate it as a practice. So rather than emphasizing on the technicalities or the nutritional requirements of this age, I am just here to talk about an idea that I hope reaches its fructification, and we are able to bring geriatric nutrition to the pride of place it deserves. So thank you once again to the Ram Manohar Lohia Institute of Medical Sciences for inviting me as a guest speaker on their virtual symposium. Today, as already mentioned, my topic is geriatric nutrition. The 3 A's: approachable, accessible, and affordable. Before I start and dive into the nitty-gritties of geriatric nutrition, let's just talk about the common understanding of the life story of us humans, biologically speaking. How do we envisage this as? So we have an infant, so infant nutrition, then pediatric nutrition, adolescent nutrition, and then we have, the adult phase of life, wherein we are busy in our work life, in our family life, stresses creep in, we lose our sleep, we near the mid-age, and then, problems start creeping up. Once we pass middle age and get into the senior citizen category, or geriatric nutrition that we prefer to call it, the picture that is in most of our minds is of an individual who's stooping, who has a stick to rely on, is crippled from or is surrounded with number of health issues. Now, the purpose of my talk today is trying to change this image that we all have built up over the years. We need to dispel that imprint we have in our minds that geriatric or old age is all about losing health or having health issues or not being at the best shape of our lives. I would encourage and I would hope that after this talk, we move towards shifting the paradigm, shifting the image that we have of old age to something like this, to a fruitful life, well lived, and old age being enjoyed, both in the sense of mental and physical health. About wellness, we need to emphasize that geriatric nutrition doesn't need to be therapeutic nutrition all the time. It doesn't need to be something wherein we are constantly addressing disease issues. It's easier said than done. And lately we have seen that even before people reach old age or the senior citizen category, as we call it, due to not following a healthy lifestyle, exercise, sleeping well, avoiding stress, the problems of old age have started creeping up much earlier. Now, there's a very recent study that had been conducted, and it said that Indians per se, due to our inherent lipid profiles and lifestyle choices, have started having coronary heart diseases 20 years prior to what was being seen earlier. And what really becomes important is we start sensitization of the population. We start sensitization of individuals right from the beginning, so that once they reach the beautiful phase of life wherein they are free of most work-related pressures, they can enjoy family life more, can sit back and relax, they are healthy enough to do it. Why I stress on sensitization is that I was really shaken by this news we received just a couple of hours back, that I'm sure most of us recognize this actor, Siddharth Shukla. He's been in news lately because of the Big Boss season. He died of a massive heart attack at the age of 40. And this is something that has been happening over a period of time. We saw, the husband of Mandira Bedi from the industry who died of a sudden heart attack. They looked perfectly healthy from the outside. But, the stresses of life, the faulty eating habits, all those cause a heavy burden on our system. And this needs to change. We need to start talking about health, not just dividing it into phases of life. We need to talk about health in a very holistic manner. And we need to start addressing geriatric nutrition, not when we reach that stage, but early on. How do we do that? That's the most obvious question on everybody's minds. The most important point that I feel is through sensitization. That is the first step wherein we can actually aspire to make a difference. Who do we sensitize? We have to sensitize individuals, right from school children. We need them not to keep thinking of the image of old people or senior citizens as people who would not be able to perform their functions well, who would not be able to live a full life. And we need to start encouraging individuals from very early on to start taking care of their health. Second, we need to start sensitizing dietitians, nutritionists, and mental health professionals of addressing issues very, very peculiar to the geriatric stage of life. We need to sensitize communities who are better equipped to handle healthy senior citizens. We need to sensitize the public sector and the policymakers to help us bring this change. And as Dr. Renuka had very rightly mentioned, that change is very difficult. And therefore, she shared a beautiful flowchart of how we can bring about this change at various levels. And that is what we should try to do. As I had already mentioned at the beginning of my talk, that I'm not here to talk about technicalities. I'm here to talk about how should we address geriatric nutrition in a holistic manner. How can we make health choices, nutrition, wellness, accessible, approachable for our senior citizens? So as mentioned in the topic, today I will be concentrating on the 3 A's and how should we achieve those 3 A's. The first that I would like to address would be approachable. Now, when I talk of approachable, what do I mean? Who do we have to make approachable? The first is obviously the individual or the senior citizen in question. We need to address their needs in such a way that they feel that we are there to help them, that we truly and genuinely understand their needs, not something out of a theoretical education that we have received and we will prescribe them the set number of calories, the set number of proteins, without any kind of personal feeling of how they actually want to be addressed. So for them to be made approachable and to open up to us as wellness advisors or dietitians is to think from their level. The second, the dietitian, nutritionist, the caregivers have to seem and be genuinely approachable, that the person in question can freely address their concerns to you and feel, to be at a place or being talking to a person who genuinely cares. The third is the establishment. And by the establishment, I mean hospitals, clinics, old age homes, parks, or recreational activities. All these should be made welcoming for the senior citizens. Now, oftentimes we've seen that for able-bodied people, everything is, perfect, and we can walk through immaculate hospitals and clinics and, be attended to. But oftentimes there is paucity of basic ramps, which slowly is changing, but still there's a long way to go. There is paucity of wheelchairs. There is paucity of, some kind of attendant who can help them get what they need. And therefore, approachable establishments are the need of the hour. And the immediate family. What happens is that, people get so involved in their day-to-day activities, they start forgetting as to how somebody who's not so busy or not, engaged in day-to-day activities would feel. And therefore, the senior citizens sometimes don't have someone to actually freely talk to. And therefore, the immediate family members need to be sensitized to the needs of the senior citizens and seem approachable. For some reason, okay. The next point is the community. We have wonderful parks around here. We have malls, we have community centers, but are they truly catering to the needs of the senior citizen? Are they truly catering to the special needs that might arise during that time? And therefore, the communities need to be more approachable. The neighbors, the community centers, the parks, activities around, so that the senior citizen feels welcome. Now, I have already touched upon this point in the earlier slide as to accessible. So we need to ensure that there's accessibility to basic facilities, amenities, and needs pertaining to this age bracket. What do we need to make accessible? Hospitals, as I already mentioned, for able-bodied people, everything is perfect. But for senior citizens, we need to make hospitals accessible. We need to make public transport accessible. And I truly understand we have paucity of time, so I will wrap this up pretty quickly. I'll always be available on my email or otherwise if you want to discuss any point in particular. We need to make banks accessible, public services and emergency facilities accessible. Because oftentimes, if some eventuality or some emergency befalls a senior citizen, they actually have no way to contact these emergency facilities. And therefore, you know, a lot of products are coming up, but we still need more media coverage, more advertising, so that people know about these. Like, you know, back in the US and Europe, they have these lockets with an emergency button. So if something happens and they need help immediately, they would just press the button and the call would straight away go to, you know, the central emergency number and help would arrive. So we need such things in India too. Community activities, once again, so they should be welcoming enough. They should be aimed at the senior citizens. We need more of senior citizen groups wherein people can come, interact, enjoy laughter clubs, walk clubs, activity clubs, and the likes, and self-help groups, so that they actually know who to reach out when they need help. Then it has to be affordable. Healthcare needs to be affordable. Healthy foods need to be affordable. Senior citizen-centric diet products need to be affordable. And special promotions in everyday amenities would help them move towards a healthier lifestyle. And most importantly, family time. We should strive to make them, you know, part of the conversation, part of the solution, and give them time. That is the most precious thing for them. The take-home message from my talk is simple. Geriatric nutrition deserves a pride of a place in dietetics, and we need more brainstorming as to how to make it so. Thank you so much for listening. And I'm glad Poonam didn't have to remind me about time. I made it very short and crisp, but I just
Thank you, Vandana. I know I have really bothered you to make it crisp and short just because of the time frame. And because of this time frame, one of our speaker who is from USA, she couldn't make it, so she has just sent her audio message with us. So I would request Shreya, can you please share the CV of Mary Murphy so that I can introduce her and then we can listen her audio, just because we have, fall short of time. So I have to now manage with this. Mary Murphy, she is MSRDN, CSSD, CDN, Wellness Promoter, New York, United States, owner and founder, registered dietitian, M.B.B.S Nutrition and Wellness 2017 till present, registered dietitian, CDCES, Marcis College, New Pals 2018-20, registered dietitian, Live Well Eating Disorders Treatment Program 2018, registered dietitian, the Illinois Skilled Nursing Facility 2018, adjunct lecturer, Queen's College 2018, clinical dietitian, Aramark Vasar College 2015 to 2017. She has various affiliations too, and she has various certifications like certified dietitian, nutritionist, certified yoga instructor, and certified specialist in sports dietetics. So here we go with the audio presentation, like the recorded presentation of Mary Murphy. Thank you, Vandana. Your session was very nice. And now I would request Shreya to share this.
Private practice in the Hudson Valley of New York, which is just north of New York City. And I'm so happy to be here today to share a little bit with you about functional nutrition. So we'll be covering the characteristics of a functional approach and how those set the functional model apart from what I'll call the conventional model, which we can think of as conventional Western medicine or nutrition. And then we'll be touching on how this is relevant within the healthcare system today. Functional medicine is a personalized, systems-oriented model that empowers patients and practitioners to achieve the highest expression of health by working in collaboration to address the underlying causes of disease. So we'll be unpacking this statement over the next few minutes here. So I like this diagram to kind of demonstrate how functional medicine and the framework differ from conventional medicine. And we want to think of the medicine as an umbrella under which nutrition is housed. So you can see the leaves and branches of this tree are comprised of the various specialities within conventional medicine. And from a conventional standpoint, the focus is definitely on these branches and leaves. So when a patient comes in to see a practitioner, where they are evaluating the signs and symptoms with the goal of diagnosing that patient and then creating a treatment plan that's going to address and alleviate those signs and symptoms of the disease. Now, where functional medicine differs is below those branches, down into the trunk, down into the roots that support and feed the upper branches of the tree. And so you can see that we look in a functional model at systems, and within the systems, we look for imbalances. In nutrition, we are specifically looking at primarily at a few systems, including assimilation, where we focus on digestion, but also in terms of transport and energy. And so then we're looking for those imbalances, and then we are evaluating any potential antecedents and triggers within a patient that we're seeing. And then we're creating a treatment plan that addresses the root causes, which you can see at the bottom of the tree. So what about the nutrition aspect? What about functional nutrition? What is that exactly? So I mentioned that this is a personalized approach, and you can think of it as a patient-centered approach. So rather than evaluating the symptoms that we see in isolation in a patient, we are taking into account that patient's history, the family history, as well as the personal history of events or triggers that may have occurred through that person's infancy, childhood, adolescence, adulthood, that could be contributing to the imbalances that we see when the patient comes to see us. How is this different in a clinical setting? So you can see on the left the conventional intake questions, and those include, the patient's body weight, currently their usual body weight if it's different, GI symptoms, diet history, the particular medical diagnoses that they're walking in with, as well as the medications that they're taking and any food allergies or sensitivities that they know of. The functional assessment uses all of those criteria, as well as things such as sleep quality and duration, headache history, energy levels, supplement use, possible toxin exposure, any history of antibiotic use, as well as muscle and joint pain even. So this is a matrix that can be used to help assess a patient. And so we're basically looking for where the patient's imbalances are clustering, and then planning out the interventions accordingly. So at the bottom, you see these modifiable lifestyle factors, and those are what we're going to recommend that the patient change in order to address the imbalance. So obviously we can't modify a patient's medical history, their history of trauma, etc., but we can modify all of these lifestyle factors that you see at the bottom. And what does this translate into in terms of outcomes for patients? So in general, we see less reliance on pharmaceuticals, surgeries, and invasive procedures. And as a result, there are fewer side effects in general for patients. Importantly, the patients feel heard. They have an opportunity to tell their story to a clinician that is listening and using that information as part of their plan. Overall, this increases patient self-efficacy so that they feel like they are an active agent in their own healthcare and that they have control over treatment and outcomes. What does this mean? So why is this relevant for today? And let's look at the benefits that we see for patients as well as society and the healthcare system. We all know that the current chronic disease burden is high. We need to be prepared for this to only increase as the proportion of individuals over 60 years of age grows as it is projected to grow from 10% in 2000 to 21% in 2050. This increase will come with a dramatic increase in multimorbidity, which is the coexistence of several chronic diseases within one patient. And in these types of patients, it becomes difficult to tease apart their comorbidities from complications, and this can confound assessment. These patients also tend to heavily rely on pharmaceuticals. We'll see this in the case study in a few minutes, and often suffer side effects from those medications, which can further complicate the assessment scenario. Therefore, the model of focusing on a single disease or diagnosis becomes ineffective. What is the cost of this chronic disease burden under this single disease model for these three entities? So for patients, we see that in general, sick people tend to stay sick, and this decreases their quality of life. Within the healthcare arena, we all know that the cost of care is increasing and will only continue to increase and be a burden. In addition, we produce ineffectual workers, and by that I mean clinicians and practitioners who feel frustrated because they can't help or heal or be a benefit to these patients, these difficult patients with multimorbidities. Hi, my name is Marie Murphy. I'm a registered dietitian with a private practice in the Hudson Valley of New York, which is just north of New York. We need to be prepared for this to only increase as the proportion of types of patients, it becomes difficult. People tend to stay sick, and this decreases their quality of life. Cost of care is increasing and will only continue to increase help or burden on caregivers. Let's take a look at a functional nutrition case study from my practice. So this is she has multimorbidities. It's a middle-aged female patient, and she's coming in with her primary diagnosis that she's seeking treatment for is obesity. However, she has multiple comorbidities, and those include depression, anxiety, hypertension, hypothyroidism as well. So this patient has no true food allergies. However, she states that she is sensitive to many foods and avoids many of these types of foods that she feels trigger her. And until about a year ago, the patient was constantly gaining weight. And then she started thyroid medication and stopped one of her depression medications. And as a result of that, she found that she was able to lose 20 pounds, but regained 5 of that. From that point, she is still significantly overweight and had tried other diets with no success. Her GI symptoms, which were significant, included regular nausea, daily diarrhea, sometimes pain in her stomach, and sometimes throwing up to feel better. She was not currently exercising because of her poor quality of life. And her diet recall indicated that her intake was calorie deficient. This patient came in at 180 pounds and 5'2", which is significantly overweight. You can see that she had multiple medications as well as supplements. As part of our treatment plan, she did a food sensitivity test called the MRT test. And as part of that, she completed an initial symptom survey, which scored her system-wide symptoms based on frequency and severity. And her score for that was 89, which was quite high. So her initial plan prior to getting her food sensitivity results in included a low FODMAP diet, which did help her significantly. The addition of acacia fiber, which helped with her diarrhea. And then she got her food sensitivity testing done. Once we had those results in place, we started her 6-week eating plan, eliminating her most reactive foods. After 2 months, this patient lost 15 pounds after trying several diets with no success. She also significantly decreased her symptom score, which went down from 89 to 32. And we saw improvements in different areas, most significantly her digestive system, symptoms, but we also saw improvements in emotional and mental symptoms, as well as constitutional, skin, and weight management symptoms. So you can see that this patient was a success story because of a functional approach. So coming in for weight loss, from a conventional standpoint, we would have had her decrease her caloric intake, increase her physical activity, but with a functional approach where we were addressing her underlying issues, including food sensitivities and gut imbalances, we were able to significantly help this patient. So I hope that this overview has provided some insights for you. And this is where I can be found via email, on the web, and on social media. And I'm happy to be available for any follow-up or questions that arise. And these are some of the references that were used throughout this presentation. So I'm so happy to have been here with you today. And I look forward to hearing the other presentations. Thank you so much. Hi, my name is Marie Murphy. I'm a registered dietitian.
Thank you, everyone. Thank you, Mary, for at least making the audio recorded message possible for us. I'm really sorry for the time zone difference, and we have, you know, we are running late with our stipulated time. I'm really thankful to all the participants, to all the eminent speakers, to our chief guests, to our guest of honor, everyone who had been in this session. Our effort from Dietetics Department of Dr. Ram Manohar Lohia Institute of Medical Sciences had been to provide you with the information which can actually work from theory to play. And I hope and I feel so, I'm really, from my perception, I'm 100% satisfied with the justice what all these speakers had done to their topics and tried to accomplish this mission and vision of this symposium. So I'm really thankful to all of you and all the participants for their, you gave so patient learning to listening to our conference. I know I had taken away your lunch timings even. So very sorry for that. And once again, thank you to one and all for being a part of this symposium and helping us to make it a successful one. Thank you very much. Your queries and the questions for this particular session, some of the speakers had tried to answer in the chat box. If still they are remaining, if you have any query, you do all have our email ID. Please share your queries over there and I'll get the answers from the speakers and revert back to you. So once again, thank you. Thank you all of you for being here and for helping us to, actually make this session possible. Thank you once again. Thank you. You may leave the meeting as you feel so.